Hello to all my dear students. So today we are going to start with retina. Many of you have a lot of phobia for this also. How to understand the fundus picture, what are we looking at, what is the diagnosis. We'll make it very simple, it's a promise. Right? You're going to enjoy the journey. So give the heading retina. Let's start with the first diagram. This you had drawn with me in the introduction chapter as well. So we start with retina can be divided as central retina. Then comes your mid-peripheral part. Then comes your peripheral retina. Right? Now the central retina, it's little bit not equal, just ignore that. So this is your, in the central retina what do you have is optic disc. And which is the second main structure here is macula. Right? So macula is nothing but the central retina. So, and the most peripheral part, what did you learn with me, has dentate process, and this is what is called ora serrata. Okay, so we are starting with this, it is divided as, and this one will be the equator. It is marked from where the vortex veins are coming out. There are 4 vortex veins which drains your choroid, so, or the uveal tissue. So this is your, that is equator is marked by the vortex veins. This much is enough at our level. Okay, then we talk about, when you know about central, then this is your mid-periphery and this is the peripheral part. Now talking about what is the diameter of the optic disc, you are supposed to know all these data. This is very, very important. So all these dimensions have to be learned. It is 1.5 mm. And what is the dimension of macula? We have learned this as well, 5 to 5.5 mm. Right? So macula is temporal or nasal to the disc? It is always temporal. So this becomes a temporal side, means away from the nose, and this is your nasal side, that is towards the nose. Wherever the disc, that will be nasal, and this is your temporal side. So which eye are you looking at? How do you think you can think with me? So your patient is in front of you, right? And his macula has to be temporal to the disc. So if you think here, which eye it is? This is your left eye, isn't it? So this is your left eye. So you're looking at the left eye fundus. This is the way you have to think. So then we talk about, once this much is clear to you all, let us think in this diagram as well. So we make this diagram, we have made it so many times, and we want to understand where is the ora serrata. We all know as we are going to the periphery, we are coming anteriorly for the retina. So when you talk about, this is your pars pliccata, pars plana, right? And next would be your ora, isn't it? The peripheral most part of the retina is here. It is straddled by the part of the vitreous, and this part of the vitreous is 3 to 4 millimeter, which is spanning this ora serrata, which is called vitreous base. This is what is called vitreous base, right? So this is your ora. How much millimeter it is away from the limbus? We will learn this is 6 millimeter, 6 to 7, somewhere it is written 6. We can just learn 6 millimeters away from the limbus, or 6 to 6.5 is safest, okay? Away from the limbus is your ora serrata. Talking about pars pliccata, you have already learned with me. If you want to know down, it is 2.2 to 2.5 millimeters away from the limbus, right? Is pliccata, and 3.5 to 4 is your plana. Where do you want to give the intravitreal injections from? It is always from pars plana, so that you don't damage either structures, right? So that is around 4 millimeter. But if your patient is aphakic and there is or pseudophakic, then you can even go for 3.5 millimeter from the. So if you answer 3.5 to 4 millimeter from the limbus, your answer is correct, right? Okay, so once we have thought in this way, now we will talk about macula. So we go in detail regarding the central part of the, so when you say macula, so if you talk about what is inside the macula, most sensitive part of the retina, which is called fovea centralis, right? So this is how we are going to, if we start with the fovea, let's start with the fovea centralis, which is the most sensitive part. So this is your fovea centralis. Inside the fovea centralis is foveola. We all know this. So inside this is foveola, right? and a central depression over the foveola we all know is your umbo. Okay, so if this is the foveola, right? If this is your foveola, this is the diagram you must have seen, you must be familiar with. This much is your foveola. So foveola is around 0.35 mm. Now if you don't want to learn it, it's okay at your level, but little bit extra points are always safer to tell, right? And then comes your fovea, which is again, this is your fovea. This is 1.5 mm. Right? Now talking about just outside the fovea is parafoveal area. Now also understand this, that there is no blood supply or all the retinal vasculature is not reaching in this area. Which area I am saying? Foveola. This one is your foveola and this is your fovea. Why? We will go into more details, you will understand. So first of all, you should know this. This whole thing is therefore also called foveal avascular zone. Right? No blood supply till here. So this is your foveal avascular zone. Okay. What is outside the fovea is perifoveal area. First it is para and then peri. Okay. So first we will make a parafoveal. We make another circle. This is your parafoveal area. Right? Now, I don't want you to mug up each and every diameter, so I am not telling it here, it is around 2.5, I will leave it. And then outside the parafovea, this will become your perifoveal area, which you have learned as 5 to 5.5. So, this becomes your perifoveal area. This is a detailed structure of your, we are talking about macula. And this central depression, let us mark this as well. This is called umbo. The central depression is umbo. We are going to talk about central depression when I am going to teach you about the cystoid macular edema, how this is obliterated due to the edema and you cannot see the foveal reflex. So we will again talk about it. You will be able to relate it better there. Right, all of you? So this was about your structure here. Now once you know this much and you have this much of the idea, so what are the questions asked? First question, before I move further, most sensitive part of the retina, we will answer fovea centralis. So, this most sensitive part, this yellow circle, this is your blue one. This one is your fovea centralis. Yeah. So, you will say this is Q, most sensitive part. Then we talk about the next question they have asked you, part of retina. Written? Okay, we come to the next question they have asked you is thinnest part. So till last year we were answering ora serrata, 0.1 mm, ora serrata. I don't know why, but in 9th edition of your Kansky, it has now started saying that fovea is the thinnest part. So here we can again learn that thinnest part is your fovea centralis. Okay, so thinnest part again, fovea centralis. Let's start to answer like this from now. Okay, then we talk about is another question. I think this we had discussed earlier also, that what is the distance between the, if this is the fovea inside, what is the distance between the temporal margin of disc and fovea? What did we learn? 2 disc diameter. What was 1 disc diameter? 1.5. So we are saying it is around 3 millimeter. Make a Q. So we have just discussed 3 Qs again. Right? Yeah. And of course, from how much distance you're giving, intravitreal injection is also a Q. So don't forget these distances. Make a Q here as well. Vitreous base is the strongest adhesion to the retina is another Q. So don't forget this, make a Q and write the strongest adhesion of vitreous to the retina is at the vitreous base. So these are the questions they have asked you. Okay. So once we are clear with this, we next talk about is what are the different layers of the retina, right? Let's have a look at a few slides before we start drawing it for ourselves. Okay, so I don't want you to draw anything, just listen at this point. So, here this is your retinal outermost layer of the retina. After that will come the choroid is what? Retinal pigment epithelium. This is number 1. From then comes your photoreceptor cells, that is rods and cones, right? Rods and cones, we all know the outer segment and how this is the nucleus. These are the disc in which the pigments are there. Okay, then photoreceptor layer ke baad, what is there? Outer limiting membrane. This is the third one, or you also call it external limiting membrane. Then comes your outer nuclear layer, then outer plexiform, then inner nuclear, inner plexiform. We will learn everything. What are the cells in each layer? And after that comes your ganglion cell layer. So did you understand the cells which are in the photoreceptor are rods and cones? Now the axons from there are going to going to synapse with what? Tell me. So outer nuclear is what? It is the nucleus of rods and cones. So outer nucleus is nothing but nucleus of rods and cones. Keep listening at this time. You don't have to write anything. I'll tell you when to write. Right? And from there, the axons of this are actually synapsing with these cells. These are mainly bipolar cells. And this is what is outer plexiform. Now axons from the bipolar cells, and we also have amacrine and horizontal cells. We'll talk about it and write it again. This is just a rough idea I'm giving. This is going to finally synapse with the dendrites of the ganglion cell. So this becomes your inner plexiform, and the axon of ganglion cell is what is nerve fiber layer. And after the nerve fiber layer comes your internal, the 10th layer, it is internal limiting membrane. Right? So these are the different layers. We come back to our diagram. Now you'll find life much simple if you're going to draw in my style and understand how to do this. So let's start writing. We'll just make different lines and label it. So we start with outermost layer. We will draw like this. Please leave some space. We'll draw the choroid also. So outermost layer here, this is your retinal pigment epithelium. So we start like this here. It becomes simpler. Then there is a small gap. Please draw this gap. This is what is called subretinal space. Okay. Then comes your, what was this line? This is your layers of rods and cones. This is your photoreceptor cells. Every line is a layer. I have simplified like this. This becomes your external limiting membrane. Then next layer, outer nuclear, outer plexiform, inner nuclear, inner plexiform. Right? Then comes your ganglion cell layer. Hope you are drawing with me now. Then nerve fiber layer and internal limiting membrane. These are the 10 layers of the retina that you have to know. And of course, after that will come the condensed part of the retina, which is called the hyaloid membrane. I think, let me just space it out a little better for you all. So we draw it again here. If this is your choroid, let's make a choroid. This is your choroid. Okay, then we talk about outermost layer. This was your retinal pigment epithelium, subretinal space. Right? Okay, keep writing. This you have drawn yourself. I'm just repeating it just to create some space. You can just learn with me. Then this is your rods and cones. What is next? External limiting membrane. Then outer nuclear, outer plexiform, inner nuclear, inner plexiform. Right? Then comes your nerve ganglion cell layer, and from after that comes your nerve fiber layer. So next is ganglion cell layer, and then comes your nerve fiber layer, and here is your internal limiting membrane. Now then what I wanted to show here is, this is the condensed part of the vitreous, which is called hyaloid membrane. So this is the vitreous, and the condensed part is called what? This is called hyaloid membrane. Right? Getting it? Okay, so what will be this? This is the anterior segment of your eye. So we draw the anterior segment here, and this is your lens. Okay? So this is hyaloid membrane. This is the anterior hyaloid membrane. This will become the posterior hyaloid membrane. These are the different layers or the 10 layers of the retina. Okay, once we know this, why the subretinal space is important? Because embryologically it is very weak. So any separation of the retina, any pull always happens along the space. That means retinal detachment is not detachment of retina from choroid. What it is? It is the separation of outermost layer. This is retinal pigment epithelial layer from the rest of the layers till internal limiting. What is these called? What are these called? Collectively we call it neurosensory retina. Keep noting down. So the separation of outermost layer from the neurosensory retina is what is retinal detachment. Where it is happening? Along the subretinal space. Now draw one more thing. The innermost layer of the choroid, which is a membrane between the retinal pigment epithelium and choroid. What do you call this, everyone? This is what is Brooks membrane. We have talked about it in the uveitis chapter also. So this is Brooks membrane, right? So padha tha na, Dehlen-Fix diffuse nodules were all in the Brooks membrane, between Brooks membrane and the retinal pigment epithelium. Right. So these are the different layers, and once we know this much, and once we are clear with this much, the next very important thing is about the blood supply and the branches of what is the blood supply of the retina? What do we know? The outer layers, 4 layers, is supplied by same which is supplying the choroid. What were the arteries? That is short posterior ciliary artery. Okay. So short posterior ciliary arteries are supplying the outer 4 layers, and the inner layers are supplied by central retinal artery. Now we talk about this central retinal artery, the branching. It happens at 2 levels. So these capillaries, so we all understand artery, arterioles, capillaries, then venules, veins, right? So we are talking about here that the capillary system is at 2 levels. The blood vessels are at 2. One is between OP and IN, done like this. OP and IN means outer plexiform, inner nuclear. Here when you look at these blood vessels, they are perpendicular to the surface of the retina. And the second level where you find is along the nerve fiber layer, where they are parallel to the surface of the retina. So this is the reason. So these are the 2 blood vessels. At these 2 levels, you see the blood vessels, and alignment is so different. And this is the reason any bleeding at this level, in between OP and IN there, looks like a dot and a blot. Therefore, you see in the retina different types of hemorrhages. So this is the explanation. क्या होता है? So this is your dot and blot hemorrhages are actually the bleeding from the capillaries between OP and IN layer, right? So this is called dot and blot hemorrhage. And whenever there is a bleeding along within the capillaries along the nerve fiber layer, because they are parallel to the surface of the retina, the bleeding looks something like this, and hence morphologically we call it flame-shaped hemorrhage. So these are the 2 main. Of course, there are more like pre-retinal, boat-shaped, pre-hyaloid. I am not going to go into that detail. We will just talk about dot and blot hemorrhage and flame-shaped hemorrhage. So D for D. What is that? Dot and blot are also called deep hemorrhages, and flame-shaped are also called superficial hemorrhage. Why it is opposite? Look at it. This is the outer layer, this is the inner layer. Why is that deep and why is that superficial? Because I am looking from here. I am examining the patient from here. Therefore, for me, this is superficial and this is deep. Got it, all of you? So these are the 2 types of hemorrhages. Okay. Once we have understood this much, what are the 2 types of exudates? We will quickly revise. So 2 types of exudates. One is your exudate is when it is leaking out from the blood vessels, and these are lipids. So lipids they look like yellowish deposits. They are called hard exudates. So exudates we have learned in retina can be hard or soft. Why do you call it hard? Because the margins are well defined. So well defined margins are hard exudates. What are they actually? They are nothing but leaked lipids. These are leaked lipids. That means when there is a leakage, when will there be a leakage? When the capillary permeability increases. So capillary permeability is increasing is breaking of which barrier? Okay, let me talk about that after a short while. Let's first complete exudates. Second is your soft exudates. Soft exudates again are called soft because their margins are ill-defined. We also call them cotton wool spots. They look like cotton wool on the retina. We call them cotton wool spots, and because of the ill-defined margin, we call them soft exudates. Now, what are these actually? These are nothing but dead axons. They are axonal infarcts. So do we realize this? That more soft exudates is a more serious thing because this is happening due to hypoxia. So more soft exudates I am getting means there is more hypoxia. Okay, so keep this in mind. So this is more serious. Okay, I was talking about blood retinal barrier. Come back here. There are 2 blood retinal barriers that you have to keep in mind. One is inner, one is outer. What is inner is the capillary integrity, which means that when the capillary permeability of either these capillaries or these capillaries is increasing, What is happening is leakage. Leakage of water leading to edema, leakage of lipids which are hard exudate. And this is what is leading to also cystoid macular edema. So it is breaking of inner barrier. Okay. And we will write it in a short while. First listen. Then coming to what is outer barrier is when these are nothing but strong adhesions of retinal pigment epithelium. So strong adhesions of retinal pigment epithelium which does not allow any leakage from the choroid into the retina. This is called zonula occludens. These small strong adhesions are called zonula occludens. This is what outer barrier. Right? Let's write now. So we will say that the blood retinal barrier can be inner or outer. So blood retinal barrier, when you say inner, this is mainly capillary integrity at the capillary level. Right? So when it is broken, it can lead to what? We can say cystoid macular edema. CME is cystoid macular edema. And when the outer barrier, what is outer barrier? Strong adhesion of retinal pigment epithelium. It is not allowing any leakage from the choroid. Let us go back to this diagram. Collection of fluid in this subretinal space and a mild collection out here. One condition, of course, any collection is retinal detachment. I told you. So, when there is a very shallow retinal detachment due to a mild collection of the fluid, we will learn this in detail also, this is called CSR, central serous retinopathy. Central means that macula, serous is fluid accumulation. Okay, so keep this in mind, these are cues. Outer blood retinal barrier, if it is breaking, it is going to lead to CSR. Inner blood retinal barrier, when it is breaking, it is going to lead to CME, that is cystoid macular edema. Okay? Got it, all of you? Okay. Now, we are also supposed to learn about the different cells and the different layers. Right? Let's do it. Let's again make it for ourselves. If this was the retinal pigment epithelium and the subretinal space, the more you make the diagram, as many times you make the diagram, the thorougher you will become. So please don't hesitate to draw again and again and again. So then this is what is rods and cones. So the photoreceptors, we already know this, right? Okay. Then there is external limiting membrane. This is ELM or outer limiting membrane. What was next? Outer nuclear. So what is outer nucleus? It consists of nuclei of rods and cones. Now we are writing what it consists of. Note down please. Then we talk about outer plexiform. What is outer plexiform? When it is synapsing. What is synapsing? Axons of rods and cones with the dendrites of bipolar cells or amacrine cell or horizontal cell. So these are the three cells present where? Inner nuclear layer. Okay. So inner nuclear, what are the cells present? I mean to say bipolar cells, then amacrine cells and horizontal cells. That constitutes bipolar cells, amacrine and horizontal. Should we write it more clearly? Let me write it again. So plexiform you have understood, so I am rubbing this. We will just say here, this is inner nuclear has bipolar cells. Okay. Then we will say it has horizontal cells. We will go back to the slide also. First write it. And amacrine cell. Horizontal ho gaya, amacrine cells. Right. And after inner nuclear comes your inner plexiform. We all know it is a synapse with a ganglion cell. Then comes your ganglion cell layer. We already know. And what is nerve fiber layer? You should be very, very clear. We have discussed this in the glaucoma chapter also. Nerve fiber is nothing but axons of ganglion cells. Right? And then comes your internal limiting membrane. Where are the Muller cells? Now comes the interesting part, that the Muller cells, it spans almost the whole thickness or layers of the retina, and it is a supporting cell, right? So Muller cell is actually a supporting cell spanning from the rods and cones layer till the internal limiting membrane. So spanning from layer of photoreceptors till the internal limiting membrane. Written? If you've written, now we are going to come back to this. Look at this. Can you see this in the background? These are the Muller cells. Right? Right? So this is your bipolar cell. We talked about amacrine cells. Right? These are amacrine cells and horizontal cells. Right? I think now it's absolutely clear what are the layers and what are the cells. Now they have, sometimes can ask you the histology as well. So be very, very familiar with this also. Let's see the histology here. This becomes your choroid. And if you look here, this is your retinal pigment epithelium. The red line, right? So you'll just see the rest is your basophilic. You can see the appearance and you can know when you know the layers, right? So this is the layer of rods and cones. The nuclei would look like this, outer nuclear. Then this is outer plexiform, inner nuclear, inner plexiform. Then you will think of ganglion cell, nerve fiber layer and internal limiting membrane. So you have to be very, very thorough with the anatomy. Please be very careful about it. So these two, inner nuclear, outer nuclear, if you can make out, retinal pigment is absolutely different, right? Pigment epithelium. So next, the rest of the layers are very easy to demarcate. This slide is just showing you how at the different level, first is superficial and deeper level, OP and IN layer, we have already made how the blood vessels are synapsing. They haven't mentioned here the alignment, but I've told you and explained you. Now, next we talk about is your investigation related to the retina. Let's give the heading investigation related to the retina. The first very important investigation that we are going to discuss is angiography. So here we will be discussing about two types of angiography. Fundus angiography we are talking about, okay? So fundus angiography can be first we will talk about is fluorescein angiography. This is FFA, fluorescein angiography, okay? So fundus fluorescein angiography, when you are saying, do you understand first? Let me talk about the basics before we come to the details. What are we trying to do in angiography? We are going to study the blood vessels, right? And what do? What is the basic of any angiography study? We are going to inject dye and we are going to follow and see that flow of, we have to follow the flow of that dye and try to study the arterial phase, the arteriovenous phase and the venous phase of the flow. That's it. So this is what we are going to also do here. So if a patient has come to me for an angiography, what will be my first step? First, of course, I am going to examine him nicely and I know I have decided that I have to do an angiography. It's my patient. Dilate the pupil. Be assured that you can see the retina nicely and focus through the fundus camera. Fundus camera is again an instrument just like slit lamp. There's a different instrument where the patient is sitting and I can focus. It can help me to focus the retina very clearly. But yes, if there's any cataract, any opacity, definitely it can be a hassle. So I have to be very clear that I am able to see the retina first, then only it makes sense. Okay, so I dilated the pupil, I examined the patient and now I am injecting the dye. Now how much dye, where do you inject? This is your first question, make a cue. So where do we inject the dye? You will say antecubital vein. You inject the dye in the antecubital vein and what we do is we have a vial of 10% 5 ml of fluorescein which we will be injecting into the blood, right? And what it does is it is going to reach from the arm to the retina, the arm retina time. Okay, again this is so much different in different books, but we are going to learn around 10 to 11 seconds. Okay, so it starts appearing. So some books also say 8 seconds, so it is variable, but let's be very safe and learn around 10 to 11 seconds. Okay. So just after 10 to 11 seconds, the fluorescein has started appearing. So first, this is going into the retina. Now, first it will appear in the retina or in the choroid? It is first going to appear in the choroid. If you look at the anatomy, it will first flow through the ciliary arteries. It is going through the arteries, then it will come through the vein and then it will drain off. So if you talk about the choroid time, or you can say it may be little before, right? But don't answer anything less than 8 seconds. Okay, let me not confuse you here. The question that was asked was about antecubital vein. Arm to retina time, you can say around 10 to 11 seconds. Why? What is the quality of fluorescein or any dye here is, what is happening here? is it is taking the light of lower wavelength and emitting a light of higher wavelength. That is property which is called fluorescence. We can't use any dye and study. Na? We are using a dye which fluorescence. And what is the process of fluorescence is this only. If you look at the Vibgyor we talked about in our color blindness chapter, that okay, from the lower it is absorbing the light of the lower wavelength and emitting the light of higher wavelength. So what is happening in this case of the fluorescein angiography? We are using a blue light by the cobalt blue filter. It only permits the blue light. So if the blue light is reaching and this dye is going to emit green light. So this fundus camera will have a blue filter and a green filter. It is going to give the blue light to the retina, to this dye, and that emitted green light is what we are trying to watch. Rest of the light we are not, we are cutting it off so that we can clearly study the blood vessels. So I am not writing this because it's just a general idea that you should all have. What is fluorescence and how we go about it. Yeah. So when we look at this angiography report, so this is how it looks like. This is a normal angiography where, why you say it's a normal? You don't see anything leaking out. So the white is the dye that you are actually able to see, the blood stained with that fluorescent dye. So this is the retinal blood vessels in the superficial that you are seeing. And why is the background all white? So these are choroidal. So this is a choroidal fluorescence that you are seeing, and this is your retinal fluorescence that we are seeing. These are the retinal blood vessels. And because there is no leakage, no block, everything is visible, this is a normal angiography. Now a quick, very important points. Why is this area dark? Just now we learned that foveola and fovea has no blood vessel, right? So this is dark because the dye is not reaching here. Okay, so this is a foveal avascular zone, number 1. Okay, but what about the choroid? Choroid fluorescence should have been visible. Why is the choroid fluorescence not visible and it is dark? Because there is a dense collection of pigments at this level, right? So these, what are the pigments? What are the pigments at the fovea and foveola area? It is mainly melanin and xanthophyll. Okay, so these pigments are responsible because they are dense, right? So we are not able to see the background choroidal fluorescence, and this is the reason this area is dark. So this is a normal appearance. Now, how you have to think, what can be abnormal? Let's write. Let's write here that whenever you are doing an angiography, there can be 2 types of finding. What can be the findings? The findings can be either it is hypofluorescence, means more darker area that you just saw, like that is hypofluorescence, or it could be hyperfluorescence, which means more white area, right? Hyperfluorescence means more dye is seen, right? It's a hyperfluorescence means more of the white area, and if it is hypo means less of it. Now, what can be the causes at your level? See, there are books on angiography. We have to be very, very crisp what we are supposed to know. So, for hypofluorescence, think yourself, what can be a cause? Why is there less fluorescence and it's a darker area? Either the dye is not reaching. So, that is called capillary non-perfusion or capillary block or capillary non-perfusion. So, capillary non-perfusion or capillary block is also called CNP in short. What could be the other? Other option could be there is some hemorrhage or exudate there and I cannot see behind it. We call that blocked fluorescence. So, this darker area could be just because of the fluorescence has been blocked due to the presence of any hemorrhage or exudate that is present. Then we talk about hyper. When you say hyper means more fluorescing. So, here one very simple example, of course, common sense, leakage. Any increased capillary permeability, which means breaking of which barrier? Inner. So, that is going to cause leakage. There will be hyperfluorescence. Any other cause of hyperfluorescence I can think of? Think of your diagram that you draw with me. Just, if there is any defect in the retinal pigment epithelium, naturally the choroidal fluorescence is going to be prominent. So, the second would be RPE defect. So, what is the second one? Retinal pigment epithelium defect. So, either leakage or retinal pigment epithelium defect are caused. How can you differentiate? Is it possible to differentiate? Think, common sense. How can I differentiate that this hyperfluorescence is due to RP defect or is it due to leakage? Leakage. It will increase in size. So leakage is slowly increasing in size, but defect is always constant in size. So this is how we know that we are talking about leakage. So it will keep increasing in size. Right? So this much idea you should have about fluorescein angiogram. Now what happens is if fluorescein washes away very fast from the blood. Right? So it is around, it is bound to plasma protein, but not that much that it stays too long. Choroid is a very vascular structure, a lot of choriocapillaries from short posterior ciliary artery. Suppose there is a lesion in the choroid, it was seen that it is washing away so fast, we are missing it. So comes into picture the second type of angiography, and that is ICG. What is ICG? It stands for indocyanine green. So indocyanine green angiography is again, of course it has a property of fluorescence, right? But it is absorbing more into infrared range, right? Not in the Vibgyor range, but more towards the infrared range. So anyway, so because it fluoresces in the infrared range, if you want to just note it down, okay, this is a good information, you can write it. But what is the benefit? Why did I even remember indocyanine green? Why I am not satisfied with fluorescein? Now this is the exam question. We will learn that indocyanine green is 98% bound to plasma protein. Now it is therefore becomes too much a big molecule for being leaking out from the choriocapillaris. It stays more in the choroidal circulation for a longer time. So I can study choroid better with ICG. So you note down please, it stays for a longer time in the vasculature because now it's a bigger molecule, it will not leak out, and this is going to lead to easy studying of choroidal pathologies. And you know what was your question? The question was, what is the investigation of choice for occult CNV? Occult means hidden. CNV is choroidal neovascularization. We will talk about it. So the answer was ICG angiography. So I have now given you the exact question that was asked. So answer becomes ICG angiography. Okay? Okay. And for fluorescein, I think you should have this idea. And then another question was here about anticubital ring, which I've told you. This was one. Let's talk about the next investigation. Number 2 is your OCT. What is OCT? Optical coherence tomography. So optical coherence tomography is giving you a cross section of the different layers of the retina to the accuracy of 10 to 15 microns. It is based on the principle of interferometry. Based on interferometry, it uses light waves, not sound waves. That means when I say it uses light waves, your media has to be clear if you have to do an OCT in a patient. If there is any cataract or any opacity in the cornea, you cannot do it much. Okay, so it uses light waves, media should be clear, cannot do in opaque media, right? And then, of course, clear, partly clear, but it should be, the light should be able to pass through it, right? And you can note down, it gives a cross-sectional view of the different layers of the retina. Let's have a look. You see, this is your OCT and this is how you see it. I'm going to give you a tip. How do I know what layers? The lowermost, this one, the red line is your retinal pigment epithelium. Okay, can you see that? If we know this, now we know the different layers altogether. This is what is marked if you look here. This is the retinal pigment epithelium. Then, can you see this? This is your, I want you to notice something here. If you look at the different layers, I am not going to again and again tell the different layers. We have discussed that. But what do you notice here? We notice a dip, right? And I am saying this is a normal OCT. That means at the fovea area, this is a dip. That means from here to here, the thickness is lesser. This thickness is lesser than this thickness, right? We are looking at the macular area, but when we come to the fovea and foveola area, the thickness is less and this dip is a normal thing. Why? Because Not all the layers, 10 layers are present at fovea and foveola. So now I am giving you a very important information here. I am saying that fovea and foveola do not have all the layers of the retina. Primarily, it consists of the photoreceptors, that is the cones, and if we start counting, it is only either 5 layers in foveola and 6 layers in fovea. And you know, this is the reason. Let's go back to our layers. Okay. So if you come back to your own this master diagram here, this is the reason that because these layers are not, so OP, IN, all this is not present, the capillaries are present only at this level, isn't it? So these capillaries are not present in the fovea and foveola area, and therefore we call it foveal avascular zone, right? And this is the reason we get a lesser thickness in a normal OCT. We come to the next. What are the different findings in different pathology in flow scene and geography in OCT? We are going to learn as and when we learn the condition. Okay, so don't worry about that. We are just having a basic idea about the investigation and how the normal looks like. We next talk about is the third investigation, which is very important, is your Amsler grid test. Okay, so Amsler grid test is actually mainly a subjective test where the patient, it's like a checking the visual field. Let's have a look. So this is an Amsler grid. So can you see this is a grid with equal size square and a dot at the center, right? So actually it consists of around 400 squares. Nobody is going to ask you this. But what is important? What are we trying to test? Let's understand. It's a paper, right? It's a paper you are giving it to the patient and telling him, okay, he's holding it at a near distance of around 33 centimeters and he is asked to only one by one eye at a time, and he's asked to only focus at the central dot. And you are supposed to, and he has to tell and comment about the different squares. So what are we doing? Visual field testing. So Amsler grid test is nothing but it's a visual field testing of around, so when you're doing it near with this much, we are only concentrating on the central retina, right? So this is around 20 degrees of the visual field is tested. Just remember this important point. Okay. So if there is any pathology in the macular area, I am going to get a finding here. What could be the different findings? I could say, okay, either if everything is normal, what I am going to say is that all the squares are equally sized, everything is perfect. If not normal, what can be the different options? Either I say, okay, this line is wavy. What do you mean by this? Distortion of image. Distortion of image is what is called, I'll show you the slide there also, is metamorphopsia. Okay. So all this will happen when, keep in mind what did I say? When there is a lesion in the macula. Second finding, I can say this square is bigger. This is called macropsia. Okay. Or I can say this square is smaller. Smaller is micropsia. Okay. So these are the different, what are these? What do you call them? Disturbance of visions, which is happening in a macular lesion. Okay. So these are the not diminution, but these are different disturbance of vision. Okay. This is, so Amsler grid test, you know, it has a lot of role in central serous retinopathy patients for follow-up or in age-related macular degeneration. So whenever the macula is involved, this is a very helpful for follow-up. Please note down, it's a very helpful follow-up tool. You give the paper to the patient, he has to keep monitoring his symptoms and his complaints and see whether it is deteriorating, improving or static. Right, so this was the next investigation. Coming to the next one. Write down the next one is photo stress test. Now what is the principle of photo stress test? Just understand, if I am showing a bright flash of light in front of your eye, what happens? You become blind for some time, isn't it? And then it takes time for you to look again. So that time is what we are measuring in a photo stress test. Okay? So what are we doing? So when you are exposing the eye to the bright flash, first let's understand the test and then we will discuss its basic. So note down. In the test, what you are doing, you are showing a bright flash of light with a very near distance, right? And after that, before we are showing this bright flash of light, you have already taken the visual acuity of the patient. And suppose the visual acuity of the patient, for example, was 6 by 12. Right? Now, he cannot read below. Now you want to really go for the photo stress. So you are now blinding him with the bright flash of light. And immediately removing the light, you are seeing how many number of seconds it takes for him to see at least 2 letters of this 6 by 12 line. Okay, so whatever acuity line he has, how much time it takes for him to at least see the 2 letters of that line. That is what is called photo stress recovery time. PSRT क्या हो गया? It is photo stress recovery time. And this photo stress recovery time normally should be 30 seconds to 50 seconds. This is actually the normal value. You have to know this. But in case of, if there is a macular lesion, it is going to increase. It can even be 60 seconds on in a minutes mein ho sakta hai, okay? But in optic nerve lesion, it will be normal. This is what we are trying to differentiate when we do a photo stress test. This is your exam question. Photo stress test is used for, and the answer is that to differentiate between a macular lesion or an optic nerve. What did we just learn? In macular lesion, it is going to increase, but in optic nerve lesion, it will not. Right? So we can put a Q here. Let's understand the basic. So if you look at the basic, what is happening is bleaching of the pigments, and when there is a bleaching of, what is the return of the retinal function will depend on the sensitivity and regeneration of the pigments. So this is what we are trying to test. Time to revise our visual cycle. Okay, so Val's cycle or Val's visual cycle says, I think this is quick, let's be very quick in this. Any light that is you are showing to the patient's eye is doing what? It is turning this rhodopsin into first beta rhodopsin, lumi, then meta 1 and meta 2. Right? And if you remember, this meta 2 is also then later going to lead to release of transducin. This release of transducin is going to turn cyclic GMP into GMP by this enzyme, which is phosphodiesterase. When this happens, what happens? The sodium ion channels will close, and therefore there is the nerve impulse that is generated and is going from the your optic nerve to your visual cortex. This is through the process of what? The sodium channels are closing. We say hyperpolarization. Okay, so it is hyperpolarization process is actually where the impulse is transmitted from the light energy to the nerve impulse. What is the rest of what is happening is out here, that how this meta-rhodopsin now you have to regenerate, right? So these things are of course in the rod outer segment, and this comes also is happening in the retinal pigment epithelium, where all transretinal, this is retinol, and how with the isomerase they have to finally it has to come to all cis retinal. All cis retinal will be joining this scotopsin to again form the rhodopsin. So I think you have learned this in your different subjects also, just a quick revision of this. Right. So this is what you are testing in a photo stress test, and the crux is it is more in case of macular lesion but not affected in optic nerve lesion. Right. What is the next investigation? I hope you're writing. I'm writing here only. So our next will be ultrasound. Which scan? Did you learn this? Mainly 2 scans we talk about. Theoretically there are 3, but we talk about A scan and B scan. We had learnt in our introduction A scan is for axial length, and it is the B scan which helps us to see the posterior segment. So what are you looking at here is your B scan. You should be able to understand in B scan that this is the lens, this is the vitreous, right? This is the lens, this is your choroid, retina. If you look at the different B scans, just a quick one here. Look, this is a lesion, right? So this typical lesion, which is a collar button appearance, is what is you have learnt in your orbit also, the most common intraocular tumor in adults is choroidal malignant melanoma. So actually this is choroidal malignant melanoma. Now let me tell you, they haven't asked you yet. It's just an extra point. It appears as a collar button appearance, which is so diagnostic and so easy to see. That's why I included this slide. Okay. Look at this one. So I've taken a few pathologies for B scan, though for the rest we are going to learn with individual conditions. Here this is all a hemorrhage in the vitreous. Okay, so this is your vitreous hemorrhage it is showing. Okay, let us look at this one. This is a tumor and this is retinoblastoma. We'll be talking about retinoblastoma in this chapter at the end. And here see, this is how you will see a retinal detachment. You see the line it's separating from the neurosensory retina, separating from RP. So this is what is retinal detachment, and here I can see, can you see the peaking here? That's why you are saying that this is a vitreoretinal traction. Okay, so that was USG B scan. Right? Just have a look at the slides, that's enough. Then we talk about next point you wrote down. The next investigation is electrodiagnostic investigation. We are going to talk about ERG, electroretinogram. Now, electroretinogram tells us the activity of, so this is ERG in front of you. So this is your ERG, that is electroretinogram. So when you show light to the eye, it is giving you the activity of photoreceptor cells and bipolar cell. B for B, bipolar, easy to learn. So I want you all to draw like this. This is your simple way of drawing, or if you want to copy exactly, you can do that. So whatever it is, you get these waves. You should know what is an A wave, what is B wave, and there is also small c. Electroretinogram. Make this. This is your A wave, this is B wave, and a small C wave. Okay, done? Okay, A for photoreceptors. We are talking about rods and cones. This is exam question. A wave tells us the activity of, this has been asked at your level. B for bipolar cells. Right? Bipolar and Muller cells, it's mainly bipolar cells, and C is a very small, can you see a very insignificant small activity of retinal pigment epithelium. So this is what electroretinogram is showing us. So naturally you will see the changes in the ERG, especially in cases of dystrophies where rods and cones are involved, or in the changes where bipolar cells are affected. You are going to see that. We are going to come to those pathologies one by one. Is it okay? So how do you do an ERG if you think about this? So there are two electrodes. One is placed on the cornea or the conjunctiva and the second at the forehead. And we are taking the electrical activity. And as I said, it is bipolar and Muller cells, which also means that it is giving you the activity overall of both neural and non-neuronal cells. Keep that in mind. So naturally, if there is retinitis pigmentosa, we have learned that we are going to get in a severe case of retinitis pigmentosa, we get a flat A wave also, and even it affects the B wave, and we get a flat B wave as well. Right? Yeah. So there are a lot of, again, too many things in detail about it which is not needed at our level. So we will next talk about is some special ERGs which can be asked to you. So two names that you should know for special ERGs. That special ERGs, one can be what is pattern ERG you should know, and what is the one that has been asked in your exam. I'll make a cue here. I hope you're making with me. And this is your multifocal ERG. Okay, so when you say multifocal, let me start with this one. It's very simple, common sense. At the central 40 to 50 degree of the retina, we are taking multiple readings in multiple places. We are recording the ERG. So that means these are just multiple recordings which will include from the central retina. Just remember like this, multiple recordings from central retina. ERGs, multifocal ERGs mean multiple ERGs from different points of central retina. So that means around 40 to 50 degrees we cover of the central retina. Though central, exactly what is the definition? It is central means central 30 degrees. But here we are taking at around 40 to 50. And what is very important and asked in the exam was, it is helpful in the diagnosis of, this is what you have to learn, cone dystrophy. Just remember this much, this is helpful in the diagnosis of cone dystrophy. And it can also be helpful in toxic neuropathies and like chloroquine and hydroxychloroquine. Okay, so also in toxic neuropathies like due to chloroquine, hydroxychloroquine. You also get a maculopathy there in chloroquine. We all know about bullseye maculopathy. This may be helpful. So write down maculopathy, that is chloroquine or hydroxychloroquine. I hope you're writing it. ये हो गया multifocal. And what is pattern? Again, only one line information that we have to know, that it is indicating the activity of ganglion cells, and therefore it is helpful because it dissociates the activity of the ganglion cells, and therefore it is helpful for diagnosis of glaucoma. We all know axons of ganglion cell is nothing but nerve fiber layer. Damage of these nerve fiber layers in any typical one format is what is called glaucoma, isn't it? So, diagnosis of glaucoma, pattern ERG, multifocal ERG, cone dystrophy. Bas, itna bhi bahut hai. This is enough, right? Yeah. So, if you talk about the ultrasound B scan, one more added information, please note down, is how many hertz is used. What is the frequency? It is 7.5 to 10 megahertz. Okay, so the frequency of this ultrasonic probe is 7.5 to 10 megahertz. I think you should know this. Yeah. And rest, so I think we have talked about. So we know this. What is hyperechoic and hypoechoic area? So all these dark are hypoechoic and these white are hyperechoic. Anyway, this is done already, and this was about your ERG. What is the next investigation? The next, so this is, okay, have a look here. This is what is happening. We are doing, now we have portable instruments to record the ERG. This is also recording the ERG. Come to the next investigation and give the heading. The next electrodiagnostic investigation is electrooculogram. So what is oculogram? Electrooculogram. Give the heading. It is measuring the standing potential of your eye. So potential difference from the front and back of your eye, you can understand this way. So it is measuring the standing potential of the eye. Okay, note down. Or you can say potential difference. We are measuring the potential difference between the front and back of eye. Right. So what we are doing is, we generally place two electrodes at medial and lateral cancers. Ask the patient to move his eyes right and left. Right. So cornea is making the nearest electrode positive in respect to the other. So it's mainly the difference between cornea, and at the back is retinal pigment epithelium, which is negative. So this is generally measured as 6 millivolts. Okay. Normally this is measured as 6 millivolts. Now, in electrooculogram, what is very important for at your level you should know, it is going to be affected if retinal pigment epithelium is affected. So this is very sensitive for any disease of the retinal pigment epithelium. Now we are measuring this few cycles. We are doing it for 15 minutes in the dark and 15 minutes in the light. And what do you note down? We see what is the maximum potential in the light and minimum in the dark. So we are noting down the ratio of light peak. So we are taking this 15 minutes in the dark, 15 minutes in the light. What is the maximum potential in the light and minimum in the dark trough? This is what is called Arden ratio. This is what is called Arden ratio. Right? So this is your exam question. All of you put a Q. Then they ask you what is the normal level of Arden ratio. So Arden ratio will be around more than equal to 1.85. What did I tell you where it is affected? It will be affected when there is problem in the RP dystrophies. Right? So RP dystrophies means it is mainly affected in Best disease. It is actually one of the diagnostic for Best disease. Here the Arden ratio goes to less than 1.5. And what are the other dystrophies apart from this we are going to discuss further is Stargardt's disease, right? And it can also be helpful in chloroquine toxicity. So these are some indications for EOG. Right. It's better to learn from my side. I think it's good if you just know about Best disease and Stargardt's disease. That is good. Now there was one more question I remember. They had asked you what is a flat EOG. So when you say flat EOG, it means this time the Arden ratio is coming less than 1.25. So when the Arden is less than 1.25, this is called flat electroocular bath. Okay, let's have a look. So this is what you are trying to see, what is the dark phase and the light phase, and we take the ratio of the two in the two eyes. Okay, one more thing which is a very commonly asked question. Go back and think with me about the different layers of the retina and what are the cells they contain. Correct? This is an important and a debatable question, which is the first order neuron, second order neuron, and third order neuron. Please, a humble request to answer this way. So when you say the photoreceptors, they are just the end receptors. Okay? Please don't call it first order neuron. These are end receptors. Now, the first order neuron, when you are asked about, it is bipolar cells. Okay, so bipolar cells are the first order neuron, and this is important exam question I'm talking about. And ganglion cell, when you say ganglion cell, can we also say optic nerve? Yes, this becomes your second order neuron. Okay, second order neuron is this. And the third order neuron will be lateral geniculate body. You all remember your visual pathway? We have discussed neuro-ophthalmology. So third order neuron will be this. Right? So we are going to learn like this. Okay. This was the basic, and if we know this much, we are going to enjoy the chapter more and more. We'll start with retinal pathologies. Now when you talk about pathologies in the different diseases, let us broadly divide for our learning and easy understanding vascular lesions or vascular diseases. Okay. Number 1. Second we will learn is macular disorders. Then we will talk about hereditary fundus dystrophies. Next, we will discuss the retinal detachments, and lastly, we are going to discuss retinoblastoma. Okay, so these are the 5 broad headings in which we are now going to proceed in the chapter. We first start with vascular diseases. Okay, when you talk about vascular diseases, here I am going to talk about diabetic retinopathy, hypertensive retinopathy, central retinal vein occlusion, artery occlusion, retinopathy of prematurity, and so on, a few more. Now, all these pathologies, there is a basic understanding of pathogenesis that is very important. Then you will learn the whole chapter easily. What happens? What is the basic common pathogenesis in all these vascular pathologies? So it starts with, let us understand this way, any problem, whether in diabetes, it's a microangiopathy, isn't it? So any microangiopathy happening, or in hypertension again there is a vasospasm and problem. So whatever it is causing, the story is something like this, that any microangiopathy or any pathology or any problem in the blood vessels is leading to leakage. And leakage is leading to hypoxia. Now, hypoxia is a very big issue in the retina. I want you all to learn this immediately now with me itself. Any hypoxia is going to lead to further leakage, increased capillary permeability, and further more leakage, isn't it? It is again going to cause more leakage. What else it can lead to? It is the second thing that is happening when there is a leakage you are talking about and increased capillary permeability. Let us also add here, this is going to manifest. How do we see when this capillary permeability is more? What are we seeing in the retina? We are seeing edema, all types of edema. What do I mean by all types of edema? Means edema at the disc, edema at the macula, and edema at the rest of the retina. Right? So the all types of edema, then hemorrhages, all types of hemorrhage, we mean dot and blot, flame shaped. When capillary permeability has increased, this is going to happen. And of course, exudates, mainly the hard exudates, will be due to leakage. But now, this will mainly at this point, it is hard exudates. But now the hypoxia is increasing. You can note down in your single page only. So when the hypoxia increases more, the story goes like this, that there is release of chemotactic factors. And when there is a release of chemotactic factors, you all know it will lead to neovascularization. Neovascularization in the retina is generally described in two ways. One is NVD when it is at the disc, or NVE means elsewhere. Hope you are noting down. Either at the disc or elsewhere. And when this will happen, what is the big issue? Let's go back to our diagram. So let's think together. If there is any neovascularization, it is not as good as the original blood vessels. Why? Because it is very leaky. It will bleed a lot. Secondly, it is associated with fibrous tissue. So if these are suppose the new blood vessels here, as a tuft of new blood vessels that we have drawn. Let's use a different color. Right? So if these are the new blood vessels, it is going to bleed a lot. Can you see here in the diagram and understand this is going to fill the vitreous cavity leading to vitreous hemorrhage? One problem. If it is total vitreous hemorrhage, it can lead to blindness. Secondly, the associated fibrous tissue, when it contracts, will pull the retina, leading to tractional retinal detachment. And thirdly, any hypoxia also can involve the anterior segment. And there is neovascularization of iris, which is called, Abhi, you have to listen, okay? Don't panic. This is what is rubeosis iridis. And when there is neovascularization, it can grow into the angle leading to, we have learned this in the glaucoma chapter, neovascular glaucoma. So, any neovascularization, therefore, we can learn, is leading to 3 blinding complications. And these 3 blinding complications are what? Vitreous hemorrhage, tractional retinal detachment, neovascular glaucoma. Okay? So, again I am revising with you all. Main problem was hypoxia. It could be due to diabetes, hypertension, CRV or CR, whatever. When there is a hypoxia, it is causing more leakage, increased capillary permeability leading to hemorrhage, edema, exudate. When the hypoxia is increasing, it is leading to release of chemotactic factors and neovascularization. And when there is neovascularization, it is depicted as NVD or NVE, and it can lead to 3 blinding complications. Either vitreous is gone, retina is gone, optic nerve is gone. That is vitreous hemorrhage, tractional retinal detachment, or neovascular glaucoma. This whole story we will talk in one word. From here to here, whatever I have told, in one word we can call it retinitis proliferans. This is what is happening. Okay, so हमने इसका क्या नाम दिया? Retinitis proliferans. Right? So when I use this word with you in future topics, immediately you should know, okay, ma'am is talking about the whole pathogenesis. अब बताओ in this whole story, what is the use of the laser treatment, the photocoagulative lasers that you use in the retina? What is it doing? Interesting. What it is doing is, it is changing this hypoxia into anoxia. These are laser burns. Okay. So, PRP matlab pan retinal photocoagulation turns the hypoxia into anoxia. And when there is anoxia, there is no release of chemotactic, no neovascularization, no blinding complications. Samajh? So this is very important to understand. This is the basics of all these vascular pathology in the retina. Okay. So once we know this, next thing that they have asked you is about chemotactic factors. So another Q is about chemotactic factors. Let us learn that what are the different chemotactic factors. First, of course, most important is vascular endothelial growth factor. I am not writing full form, you write it. Vascular endothelial growth factor. Second, you will say basic, not acidic, basic. Basic fibroblast growth factor. Fibroblast growth factor. Then insulin-like growth factor. Platelet-derived growth factor. Right? Then next write down tumor necrosis factor alpha. Even this helps in angiogenesis. Chemotactic, yes. And transforming growth factor, both alpha and beta. All these assist in angiogenesis. And if I ask you which stops angiogenesis, stops angiogenesis, stops angiogenesis you will say is statins. Which inhibits angiogenesis we will say is statins, that is endostatin and angiostatin. What was the question? I said this is asked in the question. The question was, all the following are associated with angiogenesis except. And the answer was interleukins. So please we will note down here interleukins and interferons. Write down interleukins and interferons. These are not related to angiogenesis. It is related to inflammation. They are mainly related to what? Inflammation. Right? Great. So now we will start with one by one. Our first heading will be diabetic retinopathy. Let's start like this. Learn with me. So we all know it's a microangiopathy. What is the main pathology happening here? Do you all remember the pericytes? If this is the capillary endothelium and these are the capillary with the endothelial lining, what are the supporting cells or the cells for the autoregulation? These are pericytes. It's just a simple depiction for you all. So mainly the capillaries have endothelial cells, the pericytes and the basement membrane. So first thing you have to know is what are the pathological changes. So pathological changes, what is happening? Pericytes is actually mainly related to autoregulation. This is important, loss of pericytes. And second, what is happening is thickening of basement membrane. Now, because of this loss of pericytes and this microangiopathy, what next is happening is your leakage, hypoxia, and the whole story of that we have talked about, retinitis proliferans. I told you, now I am going to only speak one word, retinitis proliferans. Everything fits in. So if I ask you what is the pathology? These loss of pericytes. What is the pathogenesis? Retinitis proliferans. This is the pathogenesis. Okay, so it's so simple here, na? That if I say retinitis proliferans and we have already learned the pathogenesis with hemorrhages, exudates, edema, neovascularization, NVD, NV. Ultimately in clinical feature, this is what we are going to see in the retina. So it's so overlapping. Simple, right? Before I go to the clinical features, we are going to discuss a very important topic and important questions that have been asked. Risk factors. What are the risk factors? So the first question, which is the most important factor for occurrence of retinopathy in a diabetic patient? Note down the question. It is duration. Okay, so most important factor for occurrence of retinopathy is duration. That means even if your blood sugar is controlled, especially if I am talking about the type 2 diabetes and you are diabetic since around 25 to 30 years, that's the duration I am talking about, then you are at a high risk of getting retinopathy. This is what it means. Then they have asked you the second most important factor, glycemic control. So this becomes glycemic control. This is also a cue. This is most important and this is the second most important factor. When you say second most important, it means that if you are not controlling the blood sugar, you can get it even tomorrow, right? Okay. What can be some other factors? The other factors, of course, hypertension, blood sugar, blood pressures have to be controlled. Is there any associated nephropathy or also in cases of pregnancy, which can also precipitate retinopathy? Right? So, these are some of the important risk factors. Now, we talk about next question. Retinopathy is more common in type 1 or type 2? So, we will learn it is more common in type 1 diabetes. Next question. What is the ideal time for a first fundus examination? First fundus examination to see whether this patient has retinopathy or not will depend on type of diabetes. If it is a type 1 diabetes, we should wait for 5 years. So, after 5 years we expect. But in type 2, type 2 tend to be always diagnosed late. Because it's diagnosed late, whenever the patient is coming, please see his fundus. So we answer immediately. Right? Next question. What should be the frequency of follow-up? Now, if everything is fine, what the frequency of follow-up will all depend upon what is the stage of the retinopathy. If it is almost normal, we will say the frequency of follow-up, if everything is fine, I'll tell you in detail about the different follow-up timings, but here we will say whether it is type 1 or it is type 2. If everything is fine, then you have to call the patient after 1 year. If normal or very mild changes, then we have to call for 1 yearly follow-up. Okay, we learn 1 yearly follow-up. Right. Next question. What about in pregnancy? So in pregnancy, we recommend every trimester, yani 3 monthly follow-up. These are important cues. See, I have put cues there, so I want you all to be thorough about this. Okay? Okay, so once we know this, now we talk about the clinical features. As I said, it's all overlapping. We can divide the clinical feature diabetic retinopathy into 3 stages. Now this is an older classification but applied even today, and everything is overlapping. If we know this, we can know other types as well very easily. We divide it into background diabetic retinopathy, pre-proliferative or proliferative. Okay, background, pre-proliferative and proliferative. When you say background, common sense, that means hypoxia is less, little more in pre is just before neovascularization, and proliferative means neovascularization, common sense. Okay, so if we have understood this much, first thing is, what is the first, this is exam question again, what is the first sign of diabetic retinopathy? We should answer microaneurysms. It is microaneurysms. There is a recently asked question, which layer the microaneurysm is present. So we have to answer nerve fiber layer. We will not answer inner nuclear, we will answer nerve fiber layer. Okay, what else I am going to get apart from microaneurysm? In background, we are talking about background diabetic retinopathy. Okay, so in background, this is pre-proliferative and this is proliferative. So in background, first I mentioned was microaneurysm. Second, see, making life easy for you all types of edema, all types of exudates, all types of hemorrhages. Right? Okay. Now what happens as the hypoxia increases, I see some few signs which will give me an idea, okay, neovascularization will happen anytime. So along with these features, we get all the features of BDR, and along with that some additional feature which is giving me the hint. So what are those? Increased number of cotton wool spots. All type of exudates are in background also, but they are increasing more. We just learned cotton wool spots are what? Axonal infarcts. So more hypoxia, more the cotton wool. Second, we see large blot hemorrhages instead of normal dot and blot. What are the large blot hemorrhages? It is nothing but venous infarcts. I'll show you everything in the fundus picture. Just note it down, then we will see these clinical slides. What is the third thing that can happen is, the third thing you will write is looping and beading of the veins in capillaries. Okay, looping is this, beading is this. So this is looping and beading of the venules or veins. And what is the fourth is IRNA. What is IRNA? All of you note down. Intraretinal microvascular abnormality. Right? So IRNA is intraretinal microvascular. These are capillary shunt vessels. These are capillary shunt vessels. Okay? Intraretinal microvascular abnormalities. Now, if I see these changes, I am very alert that okay, any time non-neovascularization can happen. And what is the proliferative stage? Now, I think it's simple. All the feature of pre-proliferative, everything you will see here. Along with that, neovascularization, which is NVD or NVE. This is PDR, that is proliferative diabetic retinopathy. So this is called PDR, and pre-proliferative is called PPDR, pre-proliferative diabetic retinopathy. right? Now, once you know these are the features and these are the 3 stages, there's a newer classification which we are supposed to learn. Now, it will be easier to know this. Note down, this is ETDRS classification. It is dividing your diabetic retinopathy into NPDR and PDR. First of all, like this. Proliferative and non-proliferative. Now, non-proliferative is divided as very mild NPDR or mild NPDR, moderate NPDR, then it is severe NPDR, and the latest version is very severe NPDR. These are all non-proliferative. Now one by one. When you are only getting the first sign of BDR, that is microaneurysm, we call it very mild. Only microaneurysms. This is very mild NPDR. And when along with that you're getting all the features of BDR, this becomes mild. Easy to learn now. Means hemorrhage exudate edema. Okay, then what is moderate? Moderate is all the features of non-NPDR that you have learned, that is pre-proliferative. Remember pre-proliferative? More cotton wool spots, IRMA, looping and bleeding. So this is all the features of pre-proliferative is moderate. And what would be severe? Severe NPDR we describe by, this is exam question, 4:2:1 rule. What is this 4:2:1 rule? We come next to that. Note down. It says either, write down here, 4:2:1. Either hemorrhages and or microaneurysms in all 4 quadrants. Right? So, if you are taking this, you are dividing the retina into 4 quadrants. And we see where the microaneurysms and hemorrhage are in all 4 quadrants, or looping and beading in 2 quadrants, or, so this is or. IRMA in even 1 quadrant. This is defined as severe NPDR. Either I am getting this 4 wala component or 2 or 1. What is very severe? When I am getting 2 of these components, now I call it very severe. So, 2 or more than 2 criteria of 4:2:1 rule. This is very severe NPDR. Right? So, this is how we are going to learn the different clinical features of diabetic retinopathy. I think now it is absolutely very simple for you. Yeah, 1 or 2 more questions I want to add here which I missed it is, what is the most common cause of visual loss in diabetic retinopathy? If they ask you most common cause of visual loss in diabetic retinopathy, you will answer is edema, cystoid macular edema. So we are going to answer macular edema. And please remember, 40% of the diabetics will get a retinopathy. Okay, so 40% of prevalence of retinopathy in diabetics is 40% of diabetics will have diabetic retinopathy. Right. And we were just talking about that microaneurysms are present in which layer NFL, right? What about your, think with me, cotton wool spots? They are again your axonal infarcts. Where are the axons? Nerve fiber layer. So, we can also learn here that the cotton wool spots will be present where? In the nerve fiber layer. Again, think with me, what about hard exudates? It is leakage from the capillaries. Where are the capillaries? Either in the NFL or it is OP and IN. So, generally the hard exudates are in the OP layer. We will learn as OP layer. So, soft exudates in NFL and hard exudates in the OP layer. Okay, hemorrhages we have already discussed. So, these are the clinical features. We now talk about treatment of diabetic retinopathy. Now, treatment of the diabetic retinopathy will depend upon whether there is NPDR which is without any cystoid macular edema, or is it NPDR with cystoid macular edema, or it is proliferative diabetic retinopathy, right? So even proliferative diabetic retinopathy, if I am talking about the ETDRS classification, is, if you want to know that also, is further divided. It's not very important, it will complicate, so I didn't tell you, but if you want to know this PDR, according to the ETDRS classification, can be classified as mild to moderate or high risk according to the amount of disc area that is being covered by neovascularization. I don't want you to learn that. I'm not going to take the detail. And the third is advanced eye disease. Whenever you learn this, you hear this advanced eye disease, just go back to the pathogenesis which I taught you. All the three complications that you have learned with me as blinding, that is vitreous hemorrhage, traction retinal detachment, neovascular glaucoma. This is what is advanced eye disease. Okay, so PDR can be either mild to moderate. I don't want you to go into too many details here, or it could be said to be high risk. And third is advanced. When I say advanced eye disease, what will you learn? Advanced eye disease means VH, TRD or neovascular glaucoma. Done? I was talking about the treatment part. So here we are, that NPDR without CME just needs a regular follow-up, right? When you talk about follow-up, what is the frequency of follow-up? So let us, according to what is the NPDR, the frequency of follow-ups should be learned. If it is very mild, I told you it is 1 yearly. So here I will go for 12 monthly or 1 yearly follow-up. But once it becomes a BDR, it becomes 6 monthly follow-up. Okay, so it can vary from 6 to 12 months, or mainly 6 monthly to remember. Again, moderate, definitely 6 months. And when it is severe, it has to be 4 monthly follow-up. And in very severe, it becomes 2 monthly, 2 to 3 months follow-up. Okay? So, when you are saying without CME, that is generally we are talking about only microaneurysms, and that is very mild NPDR. So, for that we will wait. We are not going to treat. We are just going to see this patient and follow-ups. Coming to NPDR with CME. Simplifying for you all, if it is NPDR with CME, first we have to know whether this edema is very near to the center of the macula, that is near the fovea or foveola. If it is significantly dangerously near, we call it clinically significant macular edema. So how do you define a clinically significant macular edema? Is any edema within less than 500 microns from center of fovea, okay, or any hard exudates, that means any form of leakage. Any form of leakage, whether I am talking about lipids or edema, any hard exudates, again within 500 microns from center of fovea. Okay. Again, there is one third criteria. It is more needed at the PG level, so I am not going too much into that. So anyway, this CSM, if you think yes, this is a CSM, you have to confirm it. How will you do it? I am going to go for angiography. This will tell me whether it is clinically significant or not. Now, if it is so, my first line of treatment in this case has to be intravitreal injection of anti-VEGF agents. Okay? Intravitreal injection of anti-VEGF agents. Now, what are the anti-VEGFs I can use? It can be either we go for bevacizumab, this is your Avastin, or I can go for ranibizumab, or mainly what is more preferred is aflibercept. Aflibercept, which is called VEGF trap, is now preferred and seen to have better prognosis. So, we are going to give intravitreal injection of anti-VEGF agents. You should know the names of anti-VEGF agents. We are preferring this, but you should know the names. And one is ranibizumab, which is Lucentis. Bevaci is, it comes in by the name of Avastin. This comes by the name of Lucentis. Once you have done this, you will not repeat any second line of treatment till 6 months. And after every 3 months, you may repeat this injection for 3 times. You can repeat it for 3 times, I mean to say. Okay, so injections can be repeated thrice. Of course, it has to be at an interval, so this can be given thrice. Suppose it is not working, what is my second line of treatment is laser. I will again opt only after 6 months of this therapy. I will go to the second line of treatment, and my second line of treatment is laser photocoagulation. Now, laser photocoagulation, which one and how I have to do, this depends on my angiographic finding. So, a very simple way of depicting here. If this is my okay, so I'm just simply depicting this is the foveal area, okay, and this is the fovea, this is the disc, so this is temporal, this is medial. Now, when I did the angiography, suppose it is a clinically significant, means it's near to the fovea. Now, there can be 2 options. Either this leakage, I can make out, it's leaking somewhere here, I can make out this point is leaking, this point is leaking. If I can make out which point is leaking, I am going to go for focal photocoagulation. But if suppose multiple points are leaking, it's a diffuse leakage, I don't know how many points, kahan se it's leaking, then what is my treatment will be grid photocoagulation. So what is very important to understand, in NPDR with the cystoid macular edema, I am focusing only on the central retina and macular area, and I am trying to control that by either giving a focal or a grid. What is grid? What do I do in grid? I am giving 2 rows of burns along these arcuate, these are called arcuate blood vessels, okay, which curve like this. Actually, it should be not outside, isn't it? It has to be inside the retina. So, we are talking about retina here, or ignore that. So, these arcuate blood vessels, along that, I should not hit the blood vessel. 2 rows of burns and few burns I am giving temporally. This is what is called grid photocoagulation. And what was the purpose? I hope you remember, to change the hypoxia into anoxia. Right? Now we talk about after this is how we are treating. So very quick revision here. First line was anti-VEGF. Anti-VEGF can be repeated thrice, but if you have to go for laser, again you have to wait for 6 months and then go for the second line of treatment. And when you are doing that, you will see according to the angiographic pattern, either it has to be focal or a grid photocoagulation. Correct. Now we talk about if it is a proliferative diabetic retinopathy. If it is not non-proliferative but proliferative, definitely it means what? Too much of your hypoxia. So naturally my laser should involve almost the whole retina. Therefore, my first line of treatment itself is laser photocoagulation. I will go for pan-retinal photocoagulation. Pan-retinal means whole retina, but whole retina doesn't mean actually whole. We will try to spare the macular area. Keep that in mind. So what we do, if this is the disc, right? Yeah. So what we are doing is we are first giving a temporal barrage to a kind of making a boundary that I don't have to enter the macular area. And next, from which quadrant I start my PRP? I start from inferior. Why I start from inferior? So see, suppose I start from superior and there is a hemorrhage. The blood is going to settle down. I cannot see the inferior part of retina now. So my procedure is unnecessarily postponed. So it's better to start from inferior quadrant. This is your exam question. So we start from inferior quadrant. Another question on PRP is how many burns you give. So actually it all depends upon what type of, how serious the disease is, right? Generally these number of burns, especially in average mild cases that we give, we start with is 2500 burns, 2000 to 2500, or you can say till 3000. But again, it will all depend. If it is a moderate or a severe case, we may have to give more. Do you realize something? What is happening? And of course, if I am giving these burns, I am creating anoxia. That means there will be damage of nerve fiber layer and can be visual field effects. Yes, that is why you cannot repeat PRP. Maximum you do 2 times and then you will shift to the second line of treatment is what? If I've done the PRP, I still not get a desired effect, I should go for anti-VEGF. So my second line of treatment in PDR will be your intravitreal anti-VEGF injections. Is it clear? So this is how I am going to treat the different stages of diabetic retinopathy. Don't forget these 2 questions from panretinal photocoagulation, and don't forget we will generally here avoid to give laser in the macular area. So once we have made a strong base here, we will now be able to appreciate all the clinical slides. Why? Okay, we are looking at background diabetic. Why we say so? What are these? This was a very recent question of your exam. They had asked you what are these? These are hard exudates. Okay, you are looking at hard exudates. These are all hard exudates. I can see a flame-shaped hemorrhage here. I can see some dot and blot hemorrhages here. Can you appreciate this blot hemorrhage? Yeah. So this one is your dot and blot hemorrhage. This is I would say this is a dot and this one is more like a blot. Okay. So when I am going to, let us have a look here. This is again initial stages of diabetic retinopathy. We are focusing at the macular area. I see one cotton wool spot out here. Okay, can you make out? These are hard exudates. This whole thing is a macular foveal area. These are all dot and blot hemorrhages. Can you see all these? These are dot and blot hemorrhages. When I do the angiography, very clearly I see multiple hyperfluorescent dots. What are these? Microaneurysms. So these are the microaneurysms. So these dots can also be microaneurysms, right? So these are microaneurysms. All these multiple dots. Can we see all these white dots? It is showing microaneurysm. When do you call it micro? When do you call it macro? Micro means less than 100 microns. More than that, it becomes macro. Keep in mind, macro is seen in hypertensive retinopathy. Right? Okay. What is this? Again, what I see, I can see the dark spots are nothing but blocked fluorescence. So it could be a hemorrhage or exudate, but these white dots are all microaneurysms in the angiography. And why in the angiography the center is dark? Now you know it very well. Now see, this one is showing a pre-proliferative stage, that is your severe NPDR, where you can see this IRMA. So this IRMA is your intraretinal microvascular abnormality, and the typical thing about this to diagnose is that it is always between 2 smaller vessels, not the major vessels. Again, at your level, I don't think they are going to ask you to pinpoint which one is your IRMA, but you should know this. If it is IRMA, it is which stage? Pre-proliferative stage. Look at this one. So what are you seeing here? Can you realize here that what are the number of cotton wool spots have all increased so much? This is cotton wool spots. So many cotton wool spots, right? I can see the flame-shaped hemorrhages. These are flame-shaped hemorrhages. I can even see large blot hemorrhage, a patch here, right? So what are we looking at? Again, pre-proliferative diabetic retinopathy, which is what you call as moderate NPDR, right? So again, and you can appreciate the dot and blot hemorrhages, large blot hemorrhage out here, right? And then flame shaped, I think it's clear to you. So this is what is your pre-proliferative stage. Pre-proliferative diabetic retinopathy. We come to the next stage. What is this? Next slide. Next slide. What is this? Can you see? This is why I chose this to show you looping of vessel. What do you mean by looping of veins? So again, this is your blot hemorrhage. Then we have a lot of dot hemorrhages, right? So this is a cotton wool spot. You are not looking at the central retina here. You are looking at the peripheral. And how can you make this out? Because there is no disc or macula that I see here, right? So this is again a pre-proliferative diabetic retinopathy. Look at this one. So this is angiography where the Can you look at the yellow arrows? That is all this dark area. What is this? These are ischemic areas. Can we see so many dot, 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 white dot? These are all microaneurysms. And this is the tuft of new. So whenever there is white, it is leakage or it is fluorescein. Huh? So this is the tuft of new blood vessels. So actually you are looking at NVE elsewhere, not at disc. Disc is this one. Huh? So this is the disc, right? So you are looking at NVE. These are neovascularizations. All these black arrows, right? So what are we now looking at? If you see the new blood vessel, we are looking at proliferative diabetic retinopathy. So this is our proliferative diabetic retinopathy. Now we will come to this one. Let's see what are the things you can see in this slide. Let's see what we can appreciate here. Again, these are flame-shaped hemorrhages, right? Cotton wool spots. Again, large blot hemorrhage, dot and blot hemorrhages. These are hard exudates. And see carefully. What do you see on the disc? We see a tuft of new blood vessel here. So this is a case of NVD. Hence, we are looking at what? Proliferative diabetic retinopathy. Look here. So clearly, this is neovascularization of disc. This is what you are looking at is proliferative diabetic retinopathy. What we see here is NVD. Neovascularization at disc. This is NVE, where you can see the tuft of new blood vessel, which is at the periphery elsewhere. Now I think it's absolutely clear to you. So whenever you see the new blood vessel, then only you are going to diagnose that proliferative, otherwise not. And comes the advanced eye disease, where you can get a tractional retinal detachment. This is the tractional gland. So this is the traction retinal detachment. You don't see the redness, it is all detached. We are going to talk about it, how a detached retina looks more grey. Why it is looking red in an attached normal way? Because of the rich blood supply of the choroid, right? So when it is away from the choroid, it is more like a grey reflex. We can even appreciate the hemorrhages out here. Seems this is in the vitreous. So this is about your tractional retinal detachment and little bit of vitreous hemorrhage. Advanced eye disease. What are you looking at on this slide? What do we see here? What are we looking at? What are these lesions? Nothing but laser burns. Okay, when they are older, they become like this. So, can you see this? There is one straight line here. Can you notice this? This is the temporal varage we have started with, so that we do not laser the macular area. This area is not involved. We are not treating this area. But we are putting the laser burns otherwise all around. And from which quadrant we start? I told you it is inferior quadrant. Right? So this is a case of pan-retinal photocoagulation you are looking at. That was about your diabetic retinopathy. If your basics are clear, it's absolutely very, very easy. We come to the next heading in the vascular disease, hypertensive retinopathy. Any long-standing hypertension can cause effect in the retina, which we learn as hypertensive retinopathy. So we will learn it by Keith Wagner grading. Now Keith Wagner grading says that any hypertensive retinopathy is divided into 4 grades. Okay. Grade 1 is generalized attenuation. Okay. So it's a diffuse or generalized arteriolar attenuation. Attenuation, everybody knows what is attenuation. Due to vasospasm, the lumen is all decrease. So it is like due to the attenuation means lessening. It becomes due to this vasospasm which is happening due to the hypertension. So you will say attenuation, narrowing, you understand, like narrowing of the vessels. Then what happens in grade 2? Apart from these features of diffuse, we also have focal arteriolar constriction. We can even see focal spasm or arteriolar constriction. So this focal spasm becomes grade 2. And along with that, we will have AV nipping. What is AV nipping? At the artery and venous crossing, you can get different findings. Okay. So you can get due to the AV nipping changes are mainly due to the atherosclerotic plaque inside the artery. which presses on the vein, and therefore you get all those signs. So what do you get in a grade 2? We call it Salus sign, where there is a S-shaped deflection of the vein. Anyway, coming back to hypertensive retinopathy, we are focusing now. Coming back to third. Third, what you will see, apart from all the features of grade 2, if you get hemorrhages and exudates, it becomes grade 3. Okay? And when you are now looking, the attenuation is so much that the arteries look like copper wire. We call it copper wiring. Do you understand what it means? Let me show you. If this is the normal artery, right? Now if there is an atherosclerotic plaque, so the plaque could be this much or this much or this much. So when the blood column is decreasing, the reflex is different, right? So if it is shining more white, means the blood column is quite thinning due to the atherosclerotic deposition. Okay? Yeah. And then what is grade 4? Grade 4 is malignant hypertension. Right? So grade 4 ho gaya malignant hypertension, where due to the high intracranial, because of the more BP, there is increase in ICT, and what you get therefore is papilledema. Okay, due to increased intracranial tension, you get that. This is your grade 4 hypertensive retinopathy. When you talk about the AV nipping changes, so if it is, let me explain it here. If it is, suppose this is the vein which is crossing. If this is the vein, if this is a small atherosclerotic plaque here, what will happen? There is only a slight deflection of this vein. This is S-shaped deflection due to this artery. This is what is called Salus sign. But if the plaque, this is S-shaped deflection as Salus sign, which we generally learn in the grade 2 of Keith-Wagner grading. Now if the plaque is bigger, what it is doing is, it is pressing at the veins. When it presses at the veins, it becomes something like that. When the veins become something like this, this is what is called gun sign. Okay. So Bonnet sign is banking of the vein. So why I made this diagram is just that you should know why are you getting all these signs. That should be clear to you. Why are we getting all these signs? Because of this atherosclerotic plaque which is increasing and therefore affecting the vein. Right? So in grade 2, I said we mentioned, let us write it here only, Salus sign. And grade 3 you can get gun sign, Bonnet sign. Gun is too much of tapering, Bonnet is total deviation of the vein. So what is banking of that, right? So this Bonnet sign, gun sign, Salus sign, they are not hypertensive changes, they are more of atherosclerotic changes. Just keep this in mind. These are mainly due to atherosclerotics. Similarly, when you say copper wiring, and in the grade 4 we say silver wiring. Again, what are these? These are atherosclerotic changes. Right. So this was about your hypertensive, and suppose there is a hypertensive crisis where you get an acute hypertensive crisis. In acute hypertensive crisis, what happens is there is ischemia, right? So when there is ischemia due to very high pressures, the autoregulation is all disturbed, and what will happen is blockage of the vessels and ischemia. So due to the blockage of vessels and ischemia, we can get two findings. Just know the terms. One is Elschnig. You have learned Elschnig's pulse, which is posterior capsular ossification. Here you are going to learn Elschnig spot. What is this? Just one word here. These are choroidal infarcts. These are nothing but choroidal infarcts. And second, Sigrist streaks. What are Sigrist streaks? They are again nothing but, you will learn it, fibrinoid necrosis of the choroidal vessels. So these are again choroidal blood vessels, fibrinoid necrosis of choroidal blood vessels. Okay. Along with that, there will be it will also affect the retinal pigment epithelium, and there is hyperpigmentation. Now nobody is going to ask too much in detail about these things, except that I want you at your level to be very, very familiar with the terms. That Elschnig spot is again feature of acute hypertensive crisis, it is a choroidal infarct. This was asked in one of your options. So you should know this one. Segrest streaks have not been asked, but these can also be a finding of acute hypertensive crisis. How do you manage? Well, one more very important thing that I missed. When you say diffuse arteriolar attenuation, how do I know whether this artery is attenuated, this is normal? We will know it because we should know the normal AV ratio. So what is the normal AV ratio? Artery is to vein is 2:3. If they ask you VA ratio or AV, you have to be very careful. So when you say arteries to vein, it is 2:3. This is the normal. So what happens in a hypertensive patient? Right? So what happens in a hypertensive retinopathy? This becomes 1:3, right? Or sometimes 1:3 is therefore because this is happening due to arteriolar attenuation. Just remember this one. So many of you ask me, ma'am, 2:3 ratio किस चीज का? Which ratio we are talking about? So when you are looking at the fundus, let's see. Okay, so this was the slide we discussed in our diabetic retinopathy. So look here, it is the width of, we are talking about the width of the vein and width of the artery. Okay, so when you say artery is to vein, we are talking about, darker one is vein, right? So artery is to vein ratio we are talking on fundoscopy, this is seen as 2:3. Okay, so this is what we are saying. If you look at this slide, you will realize that here the arteries are very attenuated. We are getting some hard exudates as well. Okay, cotton wool spots, flame-shaped hemorrhages, and no papilledema. If there is a papilledema, I told you hemorrhage exudates are possible. So if there is a papilledema, it is grade 4 hypertensive retinopathy. See it again here. Again, if you will see, the AV ratio is so much disturbed. The veins look much broader than the artery because of the arterial attenuation. Can we see that? We see a lot of flame-shaped hemorrhages, which are more common in hypertensive or flame-shaped hemorrhages. And this is your papilledema. This is blurring of disc margin and papilledema. Right? So these are some gross findings that I am seeing here, and therefore this is again grade 4 because there is blurring of disc margin. It is a grade 4 hypertensive retinopathy. It indicates papilledema. Right? Next we talk about this slide. This is what at the periphery of the retina, these streaks, this is hyperpigmented necrosis. These are what is called Segrest streaks. These are all choroidal infarcts. That is Elschnig spots. These are, you can say, Elschnig spots. So now we know two Elschnig pearl, Elschnig spots. Okay, so that was about hypertensive retinopathy, and what is the management is to manage the blood pressure. There is one more very important question they have asked you, how will a patient of pregnancy-induced hypertension present? So though later on there can be complications, exudative retinal detachment and so on, but your first answer would be PIH patient will present with hypertensive retinopathy. Okay, he will present with hypertensive retinopathy. Okay, so if in pregnancy, if suppose it is a grade 4, grade 3 or above, it is alarming. It may be an indication for termination of pregnancy in some cases. Okay, so keep this in mind. That is why you get a reference of ophtha reference from a gynae department here. So PIH can lead to, first change that will happen is hypertensive retinopathy. Right? Okay. We come to the next vascular lesion. Apart from this, give the heading is CRVO. The central retinal vein occlusion. What are the risk factors? Who are the people who can get this problem and why it is happening? So first of all, we learn, because we do not know the exact cause, we learn the risk factors. Talking about the risk factors, first is very high pressures. A high intraocular pressure can block the central retinal vein. Second, it could be, think yourself, if the size of lamina cribosa is small, there is a chance of its occlusion at the optic disc. So small lamina cribosa will be seen in hypermetropia. So note down all of you. Next risk factor, hypermetropia, mentioned here due to small size of lamina cribosa. This is due to small size of lamina cribosa. Then we talk about the third. Third risk factor could be very important, hypertension, then blood viscosity syndromes. A few, just to complete the list, we should also know is more common in old age. Smoking can be another important factor. Sometimes even your OCPs. Right, so these are the risk factors, but I want you to learn the first 4 very nicely. Now, then we talk about is pathogenesis. So you risk factor about what is the pathogenesis? What is happening if the vein is blocked? So when there is a venous blockage, occlusion of the vein, what will happen, all of you? Any occlusion of the vein, extravasation of blood, right? Because of more pressure, increased venous pressure. When the venous pressure is more, there is extravasation of the blood. It is also causing what? Hypoxia. So again, the problem is the same which we have already learnt in all vascular pathology. It is leading to hypoxia, and this hypoxia is going to lead to the whole story of retinitis proliferans. Easy to learn now? Retinitis proliferans. Right. So we also have to learn that CRVO can be ischemic or non-ischemic. So when you talk about pathogenesis, we will think of it together. Either this is non-ischemic or it is ischemic. Right? If it is non-ischemic, then I am going to get all the features of extravasation, leakage, edema, hemorrhage. But because there is not significant hypoxia here, therefore I will not get neovascularization. Right? So what you are getting here is all the features of edema, hemorrhage, exudate, but that's it. All the features of the leakage. Right? But when it is ischemia, now it is going to follow the whole story of retinitis proliferans, leading to hypoxia, leading to neovascularization, and therefore all those complications are here. So, yani whole story of retinitis proliferans. So, keep this in mind. So, in one line we know what are we talking about. Done? Okay. We talk about clinical feature, and then again we are going to divide it into non-ischemic and ischemic. So, once there is more hypoxia, naturally it is more serious than when there is less hypoxia, isn't it? Ischemic means, do you realize that means some capillary blockage and lot of hypoxia. Anyway, one by one, when you look at a non-ischemic, there is visual acuity is decreased, but in ischemic, it is markedly decreased. It becomes less than 6/60. In non-ischemic, it may not affect the pupillary reactions. Generally, the pupillary reactions are normal in majority of the case. But if it is ischemic, you are going to get a relative afferent pupillary defect. Non-ischemic, of course, you are getting all the features of leakage. That means exudates, hemorrhage, edema. So you will get the cotton wool spots as well. Apart from leakage, some hypoxia to hai. So cotton wool spots may be there, 1 or 2. But when it is ischemic, increased number of cotton wool spots. Done? Then hemorrhages and exudates, we have just mentioned so many times, are a feature. But here's typically these hemorrhages are multiple flame-shaped hemorrhage around the disc. What do you call it? Is exam question. Make a cue. Splash sauce appearance. Okay, so in CRVO, what do you get? Specially, you may get in both, but especially in ischemic. In ischemic, we are going to get splashed sauce appearance. Right? Another important thing, all of you, think with me. I said it is ischemic is, what was the number? Number 5. Okay. I said that ischemic is whole story of retinitis proliferans. We now know, everybody knows retinitis proliferans, what it is. Now, what is the complication? One of the complication is neovascular glaucoma. So, it was seen that this neovascular glaucoma after ischemic is occurring exactly after 100 days of occlusion. And because it occurs exactly after 100 days of occlusion, we call it 100-day glaucoma, and it is a repeat important question. So, what is 100-day glaucoma? Is nothing but neovascular glaucoma of ischemic CRVO. Okay. What else? Naturally, if there is a damage and pupillary reactions are also affected, when you will look at visual field effects may be present here, but it will not be seen. Visual field is normal in this case. So these are some of the features of non-ischemic and ischemic. When there is too much of leakage, of course, you may get cystoid macular edema in both the cases. Right? So investigation. We know risk factor, we talked about pathogenesis. Always think ischemic, non-ischemic, ischemic, non. So that will become very easy for you to learn, whether it is pathogenesis, whether it is clinical features. So now we'll do the same for investigation. Again divided into non-ischemic and ischemic. Think yourself. What investigation in a vascular lesion? I do an angiography. What do I get? Angiography, I may get a leak here, but here I am going to get a leak also and a block also. Hyper and hyperfluorescence, think in that term which I taught you. So hyperfluorescence here will be leak. Here I am also getting a capillary block. Isn't it? So I may get areas of capillary non-perfusion. Okay, so this is one important investigation, that is fluorescein angiography. Secondly, if you are going to do an electroretinogram, you get a normal finding in a non-ischemic, and this is an additional point. And second, whereas an ischemic, you may get decreased B wave. B wave was for bipolar and Muller cells. Right? Okay. And of course, the third investigation that I can do in this case for CRVO is what? It is mainly OCT. Why OCT? For cystoid macular edema. What are the OCT findings? We may get the CME in both the cases as I just mentioned. Okay, then we talk about the treatment part. It will again depend upon, is non-ischemic or is it ischemic? Right? If it is non-ischemic, then what you do? So you have done your angiography, now you are very, very confirmed which type of CRVO it is. For non-ischemic, to resolve these hemorrhages and resolve it faster, we can go for IVTA. Intravitreal TA is triamcinolone acetonide. But I hope you all remember this, that any intravitreal TA means very high risk of IOP. It can increase a lot, and therefore you have to monitor that. Otherwise, you can even go for intravitreal dexamethasone in very low doses. So we have to give intravitreal I hope you have written it. It's not intravenous, it's intravitreal. Intravitreal triamcinolone acetonide, or it could be intravitreal, small doses of, write down intravitreal dexamethasone. We next talk about is, what are you going to do if it is ischemic? We all know that. If it is ischemic, there are two. One is PRP, pan-retinal photocoagulation. Now the basics are clear. Or, of course, in this case also, we may give anti-VEGF injections. Both options are open. Right? Okay, one additional thing that we can learn here, that what is the sequelae of a CRVO? We have learned in meningiomas also this term opticociliary shunt. Okay, and if this shunt, these are the blood vessels on the optic disc, if you remember. So if the opticociliary shunt is formed, it is a good sign, which means the hypoxia will be not much, it is being taken care of, and therefore neovascularization will be lesser. Okay, so sequelae we can learn it like that. Okay, so one another thing is, what about the branch retinal vein occlusion if we talk about? For BRVO, again we are getting the same features, only thing is it is at one quadrant, single branch of the vein. That branch is occluded, naturally extravasation, and all those findings will be in that quadrant. Now I want you to learn here in BRVO, which is the most common quadrant where it occurs. So the most common is superotemporal retina. Okay, so this is important, it occurs in superotemporal retina. And what will be the treatment? I'll just do a photocoagulation in this area. It's a localized thing, na? So why to do anything else? Just do photocoagulation in the particular area which is affected. Okay, so superotemporal retina, it is more common. And why it is more common? Because AV crossings are more in this area. and therefore the chances of blockages are more if it is a branch vein occlusion, right? Okay, let's have a look at the slide here. So this was your exam question slide as well. I hope you can understand this. Very simple. I see a disc with multiple flame-shaped hemorrhage around it. Can you see these multiple flame-shaped hemorrhage? I can see these cotton wool spots also. So this is a case of splash sauce appearance. This is what we call as, and it is more commonly seen in ischemic CRVO. This is splash sauce appearance. Okay, so why do you call this non-ischemic? So I see a vein occlusion with, can you see the, whenever there is an occlusion, there will also be some dilatation, right? So you look at the vein here and look at this. I can see some hemorrhage out there. What I am more interested to show you here is when I did the angiography, I can see the white dye filling all these blood vessels, right? So, but look at the ischemic type now, where when I am doing angiography here in this case, I don't see the dye filling the vein. So, this is your ischemic CRVO, right? So, when there is a vein, it's a capillary non-perfusion is seen here, and this becomes your ischemic CRVO. Let me tell you something, they will not ask you more than splash sauce appearance. These are just additional things I am just giving an idea about. If you don't want to go too much into it, it's okay. Okay, just don't make a mistake for splash sauce appearance, 100 in glaucoma. At your level, this is very important, right? We come to the next heading, and that is central retinal artery occlusion. Are we looking at cherry red spot? Can we see the attenuation of the arteries, right? And can we see this edematous retina? So we are talking about, we will write everything, central retinal artery occlusion. Give the heading. Talking about central retinal artery occlusion. Central retinal artery occlusion, again, what are the risk factors or causes? Think yourself, artery occlusion, first very important is embolism, right? So when you talk about embolism, either this emboli can be cholesterol bodies, right? And this has been asked in your exam. These are called Holland-Horst plaques. So make a cue, all of you. So one major is, so it is common in heart disease patients and in carotid artery disease patients. Keep this in mind, right? Or otherwise the emboli can also be calcific, atherosclerotic, we all know that. Then we talk about the second cause. Let us not forget, this is again exam question, mucormycosis. This can be another very important cause of central retinal artery occlusion. Make a cue there. Third, again a very important exam question, we will not forget this, COVID-19. So one major effect of COVID-19 is just a conjunctivitis, follicular conjunctivitis, or it can lead to serious thing like central retinal artery occlusion, right? Of course, a few more causes that can be included are your vasculitis in collagen disorders like your polyarteritis nodosa, systemic lupus erythematosus, or you can say giant cell arteritis, right? So this can be another cause of central retinal artery occlusion. Most commonly it is embolism, which is asked in the exam. Mucormycosis is also a cue. Right. Then we talk about the clinical features. How will this patient present? So how does this patient present is a sudden, painless, marked diminution of vision. Sudden painless loss of vision or marked diminution of vision. And the vision will be up to, majority of the case have still vision of 6/60. But if suppose PL is also negative, it's a total loss. PL negative, if PL negative, it mainly indicates giant cell arteritis, right? So generally, otherwise that means because of vasculitis, otherwise it is up to 6/60. Apart from that, what is happening? There's an acute blockage of the arteries. This acute blockage leads to severe edema. And edema is so severe that almost the whole retina looks white, right? So let us understand this is due to the acute blockage of the blood vessels. acute blockage of blood vessels. We come to the third. Then marked attenuation of arteries. Again, due to the same reason, arteries are attenuated. And these marked attenuation of arteries are so much attenuated, we describe it as thread-like arteries. Thread-like arteries. Next feature, very important, asked in the exam. There can be interrupted blood column in the veins, right? And this is what is called, so you find this in the veins, we call it cattle truck appearance of blood flow, which is nothing but interrupted blood column. We also call it as box scaring, segmentation, segmented flow. Okay, so this is segmented flow. The question was in your exam, where do you see? Is it in the artery or the vein? It is in the vein. Then we talk about very important finding, cherry red spot, right? So we talk about cherry red spot. Why are you getting a cherry red spot, all of you? Think. Cherry red spot is happening in this case because all around there is edema and it is all white. But didn't we learn that the very center at the foveal area there are no blood vessels, so no edema? So from the back, the choroid is shining red. This is the reason of cherry red spot in central retinal artery occlusions, right? So this is your cherry red spot. And what is a very important question here is the differential diagnosis of cherry red spot. So next we talk about what is the differential diagnosis of cherry red spot. Right. So broadly at our level, first very important is your blunt trauma leading to Berlin's edema. Again the cause is same, any edema is not present at the fovea, choroid is shining red. So one is your Berlin's edema. What is the other name of Berlin's edema, all of you? We have learned this, commotio retini. We are talking about commotio retini. Okay, what is the second? Second will be, of course, central retinal artery occlusion. Right? Then third we will learn is, it can be, mainly, let's learn the important ones, storage diseases, okay? So you can say storage disorders or depositions. Now when you say storage disorders, again understand all these storages are happening in the ganglion cell layer, which is again not present at the center of the fovea, and therefore you see a cherry red spot. Got it, all of you? So what are the storage disorders that we have to know? Of course, first will be your Tay-Sachs disease. So this is actually learn like this, GM2 gangliosidosis. This is Tay-Sachs. You get it in Tay-Sachs disease, or it could be Sandoff disease. Then GM1 gangliosidosis. Okay, I hope you're learning along. This can be of two types, type 1, type 2. It is type 2 which has got cherry red spot, not type 1. Type 2 has cherry red spot, not type 1. Then, of course, Niemann-Pick, we shouldn't forget, Niemann-Pick. Right? And you can also get in mucolipidosis. We also get cherry red spot in Gauchers. Now it's a debatable fact, somewhere it is written, it is not there, somewhere it is written, but we are going to take it that yes, it is a feature of Gauchers as well. Right? So these are the causes of cherry red spot, please keep in mind. Let's have a look. So this is your slide which is showing the cherry red spot. This is your edematous retina and attenuated blood vessels. Now pay attention. You know, 14% of the world population has got a dual blood supply. So you may get a patient who has suffered from central retinal artery occlusion, but he is still not blind. Right? What is the cause? That he is fortunate enough to have a dual blood supply to his foveal area, macular area. So what is the other artery? The other artery that is supplying is your cilioretinal artery, right? So we will draw here, please, all of you. So one is your central retinal artery, and another artery that is supplying, will draw here, this is your cilioretinal artery. Okay? So if the cilioretinal artery is present, then of course it doesn't supply the whole of the retinal area, but yes, central some part. So very small amount of field at the center is retained. You understand? So it supplies a very limited area of the central around the fovea. So if this patient has central retinal artery occlusion, and apart from that he is fortunate enough to have a dual blood supply by cilioretinal artery, then some part of the central vision is still retained and a very small field around it. A very small field around the central vision, this is what is called tunnel vision or tubular vision. Okay, so this is what is tunnel vision or tubular vision. First question, cilioretinal artery is a branch of short posterior ciliary artery, right? Okay, so if this patient has, this is again another question was on cilioretinal artery, that you have a patient with arterial occlusion, he is still not blind, what is the cause? So now you can answer that. And the next important thing, what are the causes of tunnel vision? This is very important. So when you say tunnel vision or tubular vision, let us think one by one. First we are going to write a central retinal artery occlusion with cilioretinal artery, correct? Then what is second? We learned in neuro-ophtha, if both side PCA is gone, so bilateral occipital lobe lesion. So a bilateral occipital lobe lesion, though rare, but if that happens, again that keyhole vision, this is your tunnel vision because of both side macula sparing homonymous seminobia. Just revise your neuro-ophtha, right? Then of course late stage of, very important, late stage of retinitis pigmentosa. Late stage of retinitis pigmentosa. Then drugs like quinine toxicity. Or one more which was asked in the exam, vigabatrin. Vigabatrin can also lead to constriction of the visual field, right? So this is important. These are the causes of tunnel vision or tubular vision. Right? So this is the cilioretinal artery. Perfusion is retained. So this is the cilioretinal artery. So it will supply mainly the papillomacular bundle. Just remember this, it supplies the papillomacular bundle. Okay, so what is the treatment? Right? So treatment of CRA, of course it's an ocular emergency. First important question, within how much time I should be able to reopen the artery so that I can secure the retina and there is no permanent damage? Your answer will be within 90 minutes. This should happen within 90 minutes. What are the things I can do? First thing I can do is, I have to, just one aim is to decrease the pressure so much that the emboli dislodges by itself. So how do I just acute decrease of intraocular pressure I can cause so that the emboli dislodges? This can be done by, first of all, you take the patient to lie supine. You start with ocular massage, right? And third, what you can do is, you are going to start with IV acetazolamide, right? Apart from that, what else I can do? I need to go for some vasodilation. Vasodilation assistance ke liye you can go for, make this patient breathe inside a paper bag. So what happens? This is carbogen inhalation. This causes respiratory acidosis, 95% oxygen, 5% carbon dioxide, and that causes vasodilatation. So carbogen inhalation is another practical thing that immediately can be done if your patient has central retinal artery occlusion. Apart from that, the vasodilation can be accomplished by giving sublingual isosorbate. Sublingual isosorbate. And if your patient, if the cause is vasculitis, of course, if the cause is vasculitis, then the treatment will be in the different line. For vasculitis, we have to go for any inflammatory cause. We start with IV methyl prednisolone. Okay, and just remember one last thing here, that role of thrombolytic therapy is very, very limited in central retinal artery occlusion. Let's give the heading retinopathy of prematurity. Let's understand. So a premature infant, if he has any medical condition and you have to give oxygen to this child, right? Then this child may develop some changes in the retina. And this is what is called retinopathy of prematurity. So first of all, let's understand why it is happening. The blood vessels, if you want to note down, I'm just talking here, that the blood vessels in the retina develop very late. Okay, so very late in the gestation they are developing. They've started to develop late and they complete late. So what you have to learn with me, that the temporal vasculature keeps developing even after birth till 1 month of age. Now this is normal, right? Now what has happened? The child has born prematurely. And because of anything, any reason, if I am giving oxygen, the blood vessels are still developing, it undergoes a free radical injury. And this free radical injury in the blood vessels will lead to what? When there is injury in the blood vessels, it is going to lead to hypoxia, isn't it? So, any free radical injury and also too much of oxygen, when you realize if oxygen is more like a vasoconstrictor, isn't it? It is going to accentuate the hypoxia. So, this causes hypoxia, and hypoxia you all know already causes retinitis proliferations. So, let us start like this. We will write. So, what is happening? This is also one reason why ROP as a rule always starts from temporal side. Why? Why? Because temporal retina develops most late. Got it? Chalo. Let's write down the pathogenesis first. So, write down what is the pathogenesis? When the premature child is given oxygen inhalation, any oxygen inhalation will lead to, you can understand as vasoconstriction, right? It will cause vasoconstriction. Also, I said there can be free radical injury, and this is leading to hypoxia. It will cause more hypoxia, and when there is hypoxia, it leads to retinitis and the free radical injury to the blood vessels, right down here. And this is again leading to hypoxia, which is causing, now we are so much pro in this, retinitis proliferans. In one word, the whole pathogenesis will fit in. Easy? This is what is actually happening, right? Okay, so once we know the risk factors, we can also understand here. And because temporal retina develops more late, you can note it down. It always starts. So when I'm screening the child, I first see the temporal retina, and if that is okay, everything is fine. I don't have to see the rest of the retina if temporal retina is okay. So it always, as a rule, involves temporal retina. Okay. Now we talk about another important thing. At this point, 2 questions we'll solve. Which factor is more important? Prematurity or low birth weight? Because of all the explanation that I have given, we will answer prematurity. Prematurity is most important factor to decide whether this child can develop ROP or not develop. Right? Now, when you say prematurity, normally it is less than 32 weeks, and low birth weight means we are talking about less than 1500 grams. But in India, we'll put a bracket here to learn that in India, the criteria is a little different. It is less than 34 weeks and it is less than 2000 grams. Okay. And the supplemental oxygen, how much is considered as 100% oxygen. Supplemental, when you are giving, this is what is called, these are high risk factors. So these all become the risk factors. 100% oxygen. Okay. Second question. What is the ideal time of screening this child? So if a premature child, when should I see that, okay, the retinal changes have started developing here? So screening in the children, The criteria is add 4 weeks to, so again this is debatable, lot of sources are saying differently, but we are going to follow this. Add 4 weeks to postnatal age. So suppose the patient is born, the child is born at 28 weeks, we are saying by 32 weeks. So add 4 weeks to the postnatal age. And then what you do, then keep on following up for 1 to 3 weeks. Every 1 to 3 weeks follow up till the blood vessels have grown till the periphery, which is zone 3. I'll just talk about zones. Note down till zone 3. Okay? How do you do? How do you see that? Of course, if I have to see the periphery and peripheral most part of the temporal retina, then I will be doing this screening with indirect ophthalmoscopy. We have discussed this, but this is also not enough. With scleral indentation. With scleral indentation. Right? Which is the lens? Generally, we use a 28D lens, plus 28D lens. Right? Or there can be one more option. I use a wide field retinal camera instead of this. So any of the option we have to see and then do the screening or ROP. Now we talk about what are the, and whenever you are doing a screening in this child, we have to monitor for any apnea that can happen in a very small child during examination. Keep this in mind. Okay, so now we know what is ROP, what is the pathogenesis, when to treat it, what are the risk factors. Clinical features we learn in stages. So when you say stage 1, these are in stages. Stage 1 is demarcation line. So we'll draw it together, all of you. See, if this is the retina and this is the fovea, from where everything is going to start, all the process is starting from most temporal most part. So what I see is a faint line here. This is stage 1, we call it demarcation line. Why are you getting this demarcation line? Because of some arrangement of the blood vessel arc. So you can say because of abnormal branching of the blood vessels. That is makes more sense. Abnormal branching of blood vessels. This is easier. Later what will happen? It is just going to raise above the surface and form a ridge. So the next is ridge. Next is your ridge formation. Raising above the surface, this is your ridge formation. What is stage 3? Hope you are drawing with me. Stage 3 will be new vessels in the periphery in the hypoxic area, which is the hypoxic, most temporal, where the blood vessels are still not developed. So this is stage of neovascularization. Stage 4 is subtotal retinal detachment and stage 5 is total retinal detachment. Got it? So this is one staging and the features of ROP. I'll just show you the slide. Let me complete here. Talking about, once you know these features, what is plus disease? Let's see this slide. Okay, first let's understand the zone also. Why we will understand? For ROP, the retina has been divided into 3 zones. You can draw like this. First, if you want to draw, you draw it like this. So, how we are going to draw is that the first zone is a circle of 6 mm. Just double the distance between the disc and the fovea. What is the distance? 3 mm. So 6 mm circle is zone 1. So this 6 mm circle is zone 1. This is zone 1. Then what you do, if this is a temporal, we are drawing tangentially to the temporal most part. Okay. So when you draw this, sorry, not tangentially to the temporal, to the nasal. So when I am drawing a tangent to the nasal half of the retina and then draw like this circle like this. Okay. So this is what is your, almost your, as you can see the yellow part is your zone 2. So it's a, I'm very happy with the diagram, we'll be moving it. Okay, so let me show it here only. First circle you have of 6 millimeter. Just know this. This is the red part. The second is a tangent to the nasal. When you draw that circle, yellow part is zone 2. And whatever is left at the temporal crescent, as you see in the green part, this is your zone 3. Okay? So 1, 2, 3. Got it? So do you realize that zone 3 is extreme temporal? Any changes there? Okay, it's still expected, but it should not come in the center. So zone 1 and 2 involvement is a more serious thing than zone 3 involvement. That is important, right? So if you want just for yourself a rough one, you can make it. So first circle we are saying here is a 6 millimeter. Just remember that, right? And then the second is tangent to the nasal part, and then whatever is left, this is zone 3. Okay, so once we know these are the different zones, there is a term called plus disease, right? Let's see first the stages. This is the demarcation. Very fine line that you see here is the demarcation line. You will realize it more in this one. It becomes a ridge now. Okay, so now this one is called as a ridge formation. Do you realize all these changes across the temporal retina, away from the disc? You can never confuse, right? So this is ridge. This one was, again, this is the disc here. This is the temporal retina. This is the line here on, which is your demarcation line. What was the third stage? Neovascularization. So here, can we see here that there is neovascularization of the hypoxic retina. This is stage 3. What is plus is tortuosity of the vessels on the posterior retina, on the central retina. So this is what is plus disease. Any tortuosity here indicates progression. It indicates progression and that it is very, very active disease. This is what is called plus disease. So can we note down? Said plus disease is mainly tendency to progress, number 1. And this is nothing but tortuosity at least 2 quadrants of the posterior pole. Tortuosity of blood vessels at least 2 quadrants of posterior pole. Okay, there's another term, pay attention. What is rush disease? So rush disease is, as the name suggests, it is very aggressive and it's a fast progress from stage 1 to direct stage 5. It's a fast progress from stage 1 to stage 5. That's enough at our level. This is called rush disease. Okay, when we were talking about clinical features, where you have written the staging, before that, can you please add one thing? That any ROP is mainly divided as active disease, and this is the staging of the active disease. And second is psychiatrical disease. Psychiatrical disease will come after the active, of course. So once this active stage is gone, there can be psychiatrical stage. What is that? Right now. So when I say psychiatrical disease, now after the active disease, there can be complications like there has been already been total subtotal retinal detachment. There can be vitreoretinal fibrosis, right? Tractions. So this vitreoretinal fibrosis can lead to, this is important, so a little bit in and out of everything you have to know, right? Little bit of everything you have to know. We can't miss it. So this is vitreoretinal fibrosis, and slowly they can be, whenever there is a fibrosis, naturally they can be pulling the retina, dragging of the retina. So they can be dragging in the macula, common sense, you know? Dragging of macula and disc can happen. And later what happens is, there is retrolenter, behind the lens there is fibroplasia, that is fibrous tissue. Did you remember this is also a cause of leukocoria? We have learned leukocoria ke cause mein ROP, right? So it will always happen, all these retinal diseases, why you will get a white eye reflex? It is always due to fibrosis. Okay? So wrote down there is a retrolental fibroplasia, and this retrolental fibroplasia is going to lead to your leukocoria, white eye reflex. Correct. So once we know these terms, now next we talk about how do you manage ROP? Treatment. See, there were two things you have to understand, that earlier what we were following was a concept of threshold disease. Earlier we were following the concept of threshold disease. If this patient was falling in the, because see, the child is very small, right? And what is the treatment is, we want to treat the hypoxic retina. You already know any laser treatment means we are burning them. Why do you want to unnecessarily burn the retina of very small child? And one very important information for you all, that maximum cases till ridge formation, they actually regress. I shouldn't be treating any child, such a small child, unnecessarily. And that is why we are working so much on criterias. At the same time, if the child needs treatment, it should be on time. Right? That's why so much of screening is going on. Therefore, earlier the concept was, I am not going to treat the child unless he falls in the definition of threshold disease. Now, what was threshold? Now, this was given by International Classification for ROP. And what was threshold disease? It was stage 3. Which stage? Stage 3. Which zone should be involved? The difficult ones, that is 1 and 2. Right? What should be the extent of disease? How do you describe the extent of disease? If I am dividing the whole retina into clock hours, 12 o'clock, 1 o'clock, or something like this, okay? So, either 5 contiguous clock hours or 8 non-contiguous clock hours, and along with that, only if there is plus disease. This is the definition of threshold disease. If this child fits in, I am going to treat this child. Treatment is indicated. And what was the treatment? Of course, to laser the hypoxic retina. I'll come to that. Please remember, we never answer PRP in a case of ROP. We don't want to laser the whole thing, whole retina, okay? So, what is the treatment? It is generally laser of the hypoxic part. Okay, come back to, we will write the treatment separately. Now, what is followed? Then came the concept of pre-threshold disease. Now, pre-threshold disease is now followed, is this concept given by the study. The name of the study is Early Treatment Retinopathy of Prematurity Study, ETROP. So, Early Treatment ROP study has divided the cases into the diseases type 1 and type 2. Okay. So, when you say type 2, if your patient is in type 2, falls under the definition of type 2, we just put the child under observation. But if this child is fitting into the definition of type 1, it needs immediate treatment. This child needs immediate treatment. So, what is type 1 and type 2? Now, next we have to learn that. So, when you say type 1 is either zone 1, you know zone 1 is the most posterior fold, right? So, zone 1, any stage. So, this is a pain to learn actually, with plus disease. We'll try for some time, okay? When you will revise and revise and revise, you'll get it. Or it could be again zone 1, stage 3, even without plus disease. If it is stage 3, and second it can be zone 2, again stage 2 and 3 with plus disease. This is type 1, which needs immediate treatment. Now we talk about type 2. For type 2, we will learn zone 1 is involved, but stage is 1 and 2 without, every time it is without plus disease, no plus disease. Secondly, again zone 2 is involved, but if it is stage 3, but without plus disease. In such cases, we can just put the child under observation. Now, talking about treatment. Okay, so what is the main treatment that you're giving is laser the hypoxic part. Okay, and this has been your exam question many times, that no PRP, please remember this. Such a small child, how will you do it? We go for laser in indirect ophthalmoscope. Okay, So this can be done even in a sitting position. So through this we are able to. Now which laser? Of course photocoagulative laser. We have learned the photocoagulative can be argon green or it could be just ND-arg, right? 532 nm or it could be diode 810 nm. So we know this. We have done it earlier. So any photocoagulative laser will do. Now comes the question, is there any role of anti-VEGF? It has been tried, but it has seen that when you go for, but it's still, emerging, because anti-VEGF here has got a risk of recurrence. So we are seeing that there is a risk of recurrence. So you are not going to answer this. You will only answer your photocoagulation. And of course, if it is a psychiatrical disease, it has already led to traction bands and all, then you may have to go for pars plana vitrectomy for tractional retinal detachments, right? So the tractional retinal detachment, we will go for pars plana vitrectomy, right? So that was about ROP. So we come to the next heading. It is Pusch's retinopathy. So we talk about Pusch's retinopathy. What is Pusch's retinopathy? This is one question they have asked you. So let us understand the theory here. What is the pathogenesis? Any trauma. So main cause is trauma. Okay. So any trauma is going to lead to microvascular damage, and this is going to lead to occlusions and hence causing ischemia altogether actually. Okay. It's not even hypoxia, it's mainly ischemia. Had it been hypoxia, we would have got the same series of events, but this is causing. And also, what are some other mechanisms have been told? Like, apart from getting occluded and causing ischemia, it can also be not only damage. This damage is finally leading to embolism. That is also causing ischemia. Okay, and some complement system mediated inflammatory reactions are causing ischemia. Whatever it is, the net result is ischemia. At your level, we have to just learn this much, that Pusch's is due to trauma, number one, causing this, leading to ischemia. And when it is due to some other causes, what can be the other causes? Acute pancreatitis, number one, very important, asked in the exam, make a Q. Or it could be any fat or air embolism. Okay? So this is all other causes, means it is due to the fat or air embolism, I mean to say. When it is due to fat or air embolism, which is either in acute pancreatitis, it could be also in preeclampsia. Then again you get the same series of events due to ischemia, and this is called Pusch's like retinopathy. We call it Pusch's like retinopathy. So what is Pusch's and what is Pusch's like? You should know this. When you talk, what is the clinical feature in this patient? The patient complains of sudden marked diminution of vision. It goes to up to 6/60. And when I examine this patient on examination, I see multiple cotton wool spots around the disc. So this is hemorrhage in cotton wool, but mainly what is important is cotton wool spots. And when the small capillaries are blocking, we are getting what you call, these capillary infarcts they are more lighter and very, just showing you the slide, you will appreciate. We call it Pusch's Flecken. Pusch's Flecken. Okay. So these are the findings of Pusch's retinopathy. Let's see the slide. So here, this is what I am talking about. These are the cotton wool spots, multiple cotton wool spots around the disc. It is typical of Pusch's retinopathy. Trauma, acute pancreatitis, very important to know. And can you see these are what are Pusch's Fleckens, which are due to the small capillary infarcts. This is Pusch's Fleckens. Right? And these are cotton wool spots. We'll remember this, multiple cotton wool spots around the disc. And we can also see the hemorrhage, as I mentioned, we see a hemorrhage here. Right. Treatment. Treatment, we will say no effective treatment. Just remember, no effective treatment. right? Come to the next is, the last in the vascular diseases is Eales disease. Next topic, Eales disease. Eales disease, what are the points to remember? It is also called periphlebitis retini. So primarily there is inflammation around the veins, right? Mainly in the peripheral retina. What is the etiology, why it is happening? This is hypersensitivity to tubercular antigen. So there must be some infection in the past and there is hypersensitivity to the tubercular antigen. So this is an exam question. What type of hypersensitivity reaction is this? Let us learn both type 4 and type 3. But if they ask you and both are given an option, we will mark type 4. Right? What is the pathogenesis? Because there is inflammation, what is happening here is occlusion in the veins. And this is finally leading to hypoxia. We all know after that what happens is retinitis proliferans. Right? So the same course of events will happen. Okay. How will this patient present? A sudden visual drop, sudden diminution of visual acuity. Maybe this is due to the vitreous hemorrhage. And there can be floaters because of the vitreous hemorrhage. So when I examine this patient, very important, how do I know this vein is inflamed? We have talked about it earlier. There is sheathing, that is inflammatory exudates are all deposited along the vein. This is a sign of periphlebitis and this is what is called venous sheathing. So what you see here is venous sheathing, and along with that, very important both accused and very important exam question, the patient will have recurrent vitreous hemorrhage. Okay, a young male, yes, this also please note down, it is generally common in young males. This is also important point. So it's a disease of young males presenting with recurrent vitreous hemorrhage due to hypersensitivity to tubercular antigen. Right, all of you? Yeah. Okay, when we talk about the treatment part, before that, when I'm doing the investigation, because we are getting the whole story of retinitis proliferans, on fluorescein angiography, I can see the areas of capillary non-perfusion. Right? And because it is inflammatory, what will be the treatment? Of course, first is steroids. So either periocular or intravitreal, or you may even go for systemic steroids, all forms of steroids to control this inflammation. Of course, you should also go for PCR and try to find out about if there is active tuberculosis, which is rare. If so, I may need to give ATT. So ATT is plus and minus. If there is a severe CNP, now we all have cleared your concept, I may need to photocoagulate. So there can be photocoagulation in the hypoxic area or wherever there is severe capillary drop. Hypoxic area, right? So these are the treatment and this is how we manage Eales disease. So this was about your vascular diseases of retina. What was the next heading is macular pathology. The first macular pathology or macular disorders that we will learn here is CSR. What is CSR? It is central serous retinopathy. Okay, so when you say central and serous, central means and the macular area, serous is fluid accumulation. So what is the story all about? We know there is a leaky RP cells in the central retina, so that there is a leakage, there is a breaking of outer blood retinal barrier. This breaking of outer blood retinal barrier is mainly the cause of fluid leaking from the choriocapillaris into this subretinal space, right? Of course, these are the rest of the layers of the retina. We are not talking here. We are mainly discussing this part, right? So this is the main story why you are getting a central serous retinopathy. Okay, keep this in mind. This accumulation of the fluid is very mild accumulation of fluid, and therefore this is a very shallow retinal detachment. So it is this very shallow retinal detachment that is caused. Which type? Because it is due to leakage from the choroid, it is exudative. So shallow but exudative retinal detachment, this is what is called CSR and the central retina. Right, all of you? Okay, then we talk about the clinical features. What we have to remember that it is mainly again a disease of young males. So two diseases we have just mentioned for young males. Mainly, but it doesn't mean that it will not happen in females. So the ratio between male is to female is 3:1. Right? Majority of the times this disease is self-remitting if it is in acute form. So we can say the disease has two forms. One is your acute form and the other is your chronic form. Chronic form we will say when it is more than 12 months, more than an year, it becomes chronic. Otherwise, it is acute form. Okay, in both the cases, first of all, we will talk about why it happens. If we do not know the exact cause, we learn the risk factors. So the risk factors here, first important thing, any young male with type A personality, and very, very important, any steroid intake. Steroids are a very big risk factor. So generally steroids work in the retinal pathology but not here. Then stress is another very important. Another theory is about H. pylori infection. Right? These are some of the important risk factors we have to keep in mind for CSR. If the patient is in acute form, how does he present? This patient is going to, it's a macular disease. We had just discussed in axillary grid. The patient will have disturbance of vision, right? And I've already explained you what is disturbance of vision. What you will see here is metamorphopsia, which is distortion of image, and micropsia. Metamorphopsia, micropsia. Okay. Then macropsia is rare. Secondly, you may get a mild diminution of vision, and what is very interesting, listen here. If there is any RD, means the retina is little elevated. So do you realize the effective axial length is less? Less length means the patient arbitrarily becomes hypermetropic. So when I put a plus lens in front of the eye of this patient, now it again refocuses. So there is a mild diminution of vision, and this mild diminution of vision is going to go back to, it is corrected by plus lens. This is very important feature, you should know this, understand this. If why it is corrected by plus lens, any elevation of the retina is making the patient hypermetropic, you put a plus lens and it will go back to, the vision goes back to 6/6. Okay. Now this patient has come to me, a young male, he is saying I cannot see properly, mujhe tedha medha dikh raha hai and all that. And when I examine this patient, what I see, let's draw this, what I see is ring reflex. Why am I seeing a ring reflex? Because the fluid is being accumulated and there is a accumulation is causing shallow RD, and this is just a light around the shallow RD. My light of the ophthalmoscope is encircling this shallow retinal detachment. This is what is seen as ring reflex. Okay? Encirclement of the light around the shallow RD is my ring reflex. Okay. What should be my investigation I can do? This is very important part, again asked in exam. Ring reflex is exam question. This is also exam question about, one more important thing about acute form, it is generally tending to be self-limiting and it is not requiring treatment. This is also exam question. Right? Remember this. Okay, have a look here. This is a case of CSR, and what you see is the ring reflex. The arrows are there to show you the accumulation of fluid here. Okay, so this is CSR. When I do an Amsler grid, this is the metamorphopsia which is seen on the Amsler grid. And when I am doing an OCT, so optical coherence topography will show this picture. It is separation of what? RP from the neurosensory retina. It's an RD, but it is only limited to the central retina, not the rest of the retina. This is what is CSR. Right? So, and we can even see some changes here where even the pigment epithelium is being affected. Let's not go into that at present. So that can happen in a chronic form. But here, this is what is the picture of CSR. Whole of this neurosensory, these layers are the neurosensory retina, right? So this is your retinal pigment epithelium. So you can note down the in OCT, we see this. What can be the next investigation? Keep writing, please. Second can be fluorescein angiography, and there are two pictures and both are repeated questions. Either I can get this leakage in which is like a blot which increases in size. This is called enlarging blot pattern, ink blot pattern. Okay, so this is also exam question, and can you also appreciate the ring reflex, this one? This is all the elevated part of the retina, or you can say the retinal detached part of the retina. And then second type of pattern that you get is like mushroom shape pattern here, which is called smokestack appearance. Okay, so we call it smokestack appearance, or this is what is mushroom shape pattern. This is your fluorescein angiographic finding of CSR. And what happens in a chronic form, when it is persisting for more than 12 months, it is causing damage of the retinal pigment epithelium and photoreceptors. Right? So then there is marked diminution of vision or permanent diminution of vision. So in chronic form, we can note down it is actually leading to damage of RPE as well as of photoreceptors. Okay, let's talk about treatment part, which will depend whether it is acute or chronic. If it is an acute form, I told you it is self-limiting, and this is your exam question. One more thing we will add here, avoid steroids. If your patient has come to you, please see that he is not taking steroids of any form. And then talking about chronic, yes, in chronic what we are doing is we go for PDT, photodynamic therapy. So normally you see this is a standard therapy for your ARMD. Here again this photodynamic therapy, we are using the same process of using a photosensitizing dye and then focusing the diode laser to damage that particular part. But the difference is this time the concentration of the dye or the dose is lesser, half than that we give in ARMD, and also intensity of light is also less. So what we do here is we use which dye for this? Vertiporfin. Okay? Just understand this way. Write down photodynamic therapy. So, you have to understand that normally, if anything is very close to the fovea, right? So, if anything is very, very close to the fovea, I cannot use a photocoagulative laser because it damages the fovea as well. So, fovea will become the risk, will be damaged due to this treatment. Therefore, this is a means that any pathology which is near to the fovea, either we can go for that wavelength of diode which is not damaging to fovea. Simple. But that wavelength of diode will not damage anything. It is not in a photocoagulative range. So I am using a dye vertiporfin. What does it do? This vertiporfin, but this time if I am operating, I am treating a vertiporfin, I am treating a CSR, will be either 30% of the dose to 50% of dose which is used in ARMD, right? Now this acts as a photosensitizer. You have to understand this because this applies for ARMD also. So when this acts as a photosensitizer, and now I am using 689 nanometer of diode. Now this photosensitizes in the sense that now I can manage to damage even with this wavelength. This is what it means, right? This is first thing, very important, as an exam you should know. Second, any pathology near the fovea, in the latest 9th edition, it is mentioned, it is not mentioned in older books. One more option is subthreshold micropulse diode. Okay, so we will every time mention this subthreshold micropulse diode. See, when we were talking about diabetic retinopathy, we were doing the photocoagulative laser in the macula, but again only when it is clinically significant and we want to prevent any damage to the fovea, isn't it? But suppose it is very close to the fovea and I cannot go there, the leakage is there. Then I can even use that subthreshold micropulse diode as a modality of treatment even for CME, right? Even for that edema which is very near to the fovea, right? So this was about your CSR. These are the important points that we have to understand. Next we talk about, which is the next pathology, macular pathology that we will learn is your CME, cystoid macular edema. Oh my God, so many times we have been saying this. Why do you call it cystoid? Because we see cystoid spaces filled with fluid. So what is the other type? Amorphous. So keep in mind, amorphous is irreversible, but cystoid macular edema can be reversible, right? So first we start with what is the etiology, why you are getting edema. We have been reading it for a long time. So, okay, can we just remind ourselves, CME is due to breaking of inner blood retinal barrier, right? It is due to your increased capillary permeability, which is breaking of inner blood retinal barrier. This is due to increased capillary permeability. Now, etiology first can be any inflammation. Any cause of intermediate uveitis or posterior uveitis can lead to CME. We have learned this. So, remember that intermediate uveitis or posterior uveitis. What about next? Second cause can be vascular. All these causes, vascular diseases that you have grouped and learned with me, you know that we can get a CME there, right? Then third is degenerative, and here we have to learn that, or retinitis pigmentosa, which is actually a dystrophy, not degenerative. So retinitis pigmentosa is one cause of CME. The CME can be an association in this. What about the next? This one we have mentioned in cataract chapter as well, Irvine-Gass syndrome, right? So Irvine-Gass syndrome is nothing but this is CME after cataract surgery. CME after cataract surgery. Now pay attention. This is exam question. What are the drugs that can cause CME? This has been asked. Niacin. It can also be caused by PG, prostaglandin analogs. And if you give epinephrine in FAK glaucoma, if you're treating, so avoid epinephrine in FAK. If you give this has been also been an exam question. We avoid it in FAK glaucoma. Even if you want to give, you don't give this. Why? Because epinephrine in FAK can lead to cystoid macular edema. Okay. So once we know these are the causes, how will the patient present? Any edema at the macula, definitely diminution of vision, isn't it? So we see diminution of vision, and of course macular lesions can lead to metamorphopsia. These are the clinical features for CME. When I examine, did you remember I talked about umbo? So in a normal person, the light of my ophthalmoscope will shine at the very center of the fovea, that is that small depression which we call umbo. If there is edema, now this light is not shining. This is also on examination, we call it foveal reflex. I don't want you to be confused with what we have learned that foveal reflex formation occurs by 5 to 6 months. That was about maturation of macula. Here, this is on examination finding where the light shining on the umbo, that is called foveal. So on examination, I can see absent or dull foveal reflex. Okay, absent or dull foveal reflex. Very important investigation. We have questions here. Investigation, let's see. The first investigation you will note down is optical coherence tomography. What do you see here? So clear. These are all cystoid spaces filled with fluid, as you can see here. Which will be the layers? Think yourself. The blood vessels are between OP&IN layer and an NFL layer, right? So it starts from OP-IN and it can go up to NFL layer, right? So these are the cystoid spaces, which is typical of cystoid macular edema. You don't take even a second to diagnose this. What is the second investigation is, of course, angiography is again exam question. So OCT picture of CSR and CME are important. They can be asked in your exam, okay? Then we talk about, this is also exam question, what is this leakage known as? All of you? Can you see it is all in the radial pattern like this? This is CME image, this type of leakage is called flower petal pattern. Okay. Do you remember we talked in neuroretinitis about deposition of hard exudates, which was called macular star? So the question is, why all the leakages, whether it was leakage, simple leakage, or it is exudates, lipids, why it is radial? Why it has to be always radial at the macula? Note down all of you, understand this. Outer plexiform layer at the macula is radially placed. Okay, so this outer plexiform layer at macula is radially placed, is radial, and this is what is called Henle's layer. It is called Henle's layer. It is due to this Henle's layer that all the leakages are radial. That's why you're getting macular star. That's why you're getting flower petal pattern. Now we talk about treatment part. Once you have discussed OCT, we have discussed fluorescein angiography. Coming to the treatment. So when you talk about treatment, what you can do for CME? Of course, we can start with NSAIDs. Okay. Non-steroidal, because inflammation is one important thing. Preferably indomethacin is considered quite effective. We can also give steroids. So here we can give steroids. We were not allowed to give steroids in CSI, remember. Or we can even go for, of course, acetazolamide, carbonic anhydrase inhibitors. That is acetazolamide. Right. And of course, any macular edema associated with diabetic in the vascular pathologies, we can even go for laser treatment. We have done that, right? We have discussed it. That was about CME. One more thing, we forgot to see the slide of Eales disease, right? Eales, yeah. So this is Eales disease with peripheral. Can you see the venous sheathing which is so prominent? And this is the hemorrhage, right? So some part is anterior, it seems in the vitreous, and some part along the, so this seems to be more in the vitreous here. So vitreous hemorrhage, or some part could also be a part in the retinal hemorrhage. We can see this as flame-shaped hemorrhages as well. It's difficult to comment here in this slide, but you should know the features. So this is what is Eales disease. Our next heading would be pathological myopia. When do you call it pathological myopia? It means any myopia with fundus changes. So any myopia when there are changes in the retina, why it is happening? Generally due to overstretching of the retina. Right? Too much excessive axial length, stretching of the eyeball, stretching of the retina are causing all these changes. Just remember that. So what are the different changes of pathological myopia? So we will first define this myopia with fundus changes as pathological myopia. Why it is happening, I just told you. Let us learn by making a diagram. Okay, let me take a fresh page, a bigger one. Okay. So what are the findings? First of all, what you can see, if you start here, overall fundus, you see prominent choroidal vessels. I am going to show each and every slide to you. First, we will note it down and make this diagram. So when the choroidal blood vessels are more prominent, due to attenuation of the retinal pigment epithelium, we call it tigroid fundus or tessellated fundus. Right? We can even see, then you can see a greyish shadow around the disc, which is not only temporally but almost tends to be all around. A temporal crescent is very normal, but this is all around. This is peripapillary atrophy. Right? So this greyish shadow is nothing but peripapillary. We call it annular crescent. What do you call it? Note down, annular crescent. Okay, then too much stretching will lead to hemorrhage and pigments, right? So this hemorrhage and pigments at the macula is what is called Foster Fuchs spots. We also call them Fuchs flecks or flecks. This is also a cue. Right? Then what else I can get? I can get chorioretinal atrophic patches. Chorioretinal atrophy. At the peripheral retina, very commonly seen is degenerative change which looks like a lattice network like this. This is called lattice degeneration. So what we look here is, what we see here is at the periphery of the retina, lattice degeneration. Again, exam question. Now it can degeneration, any alteration of the anatomy apart from the normal. So this degeneration, it can degenerate and lead to hole formation. Think yourself, go to your layers of the retina. Any hole formation means water is going to go into the subretinal space, again leading to retinal detachment. And now this is what is called rhegmatogenous. Rhegma means hole. Rhegmatogenous retinal detachment. Okay, what next I can get? Elongation of the eyeball is going on, and it can lead to staphyloma. We have learnt in sclera also. So posterior staphyloma, ectasia posteriorly is called posterior staphyloma. This is also a cue. And excessive stretching can also break the Brooks membrane, and what you see them as like these are called lacquer cracks. Hope you are drawing with me. These are lacquer cracks. What are lacquer cracks? Write down break in the Brooks membrane. Break in the Brooks membrane. Any break in the Brooks membrane will lead to this, and this can lead to what? Choroidal neovascularization. Okay, let's have a look at these slides. It will be more clear to you. So this is what is called tigroid fundus, where there is a prominent choroidal blood vessels. First of all, we will see this. Secondly, what I can see in this slide is peripapillary atrophy, that is annular crescent. Right? And can you see these white streaks? These are lacquer cracks. Lacquer cracks are break in the Brooks membrane and can lead to choroidal neovascularization. So either it leads to choroidal neovascularization, number one, and secondly it can also lead to hemorrhage, which is called coin hemorrhage. I'll just show you this. Any crack can lead to. Then we also talked about chorioretinal atrophy. So this is what is we are talking about. The chorioretinal atrophic patches can be seen as a part of the pathological myopia. Yeah. So this is what is coin hemorrhage due to lacquer cracks. What is this? You are not able to see, you are not seeing the disc, you are seeing the periphery of the retina, and this is what is lattice degeneration. Second, next what you are seeing here is the arrows are showing this is what is posterior staphyloma. Ectasia posteriorly is posterior staphyloma. Yeah, this was what I was talking. Sometimes the lattice can be pigmented. This is a pigmented lattice degeneration. And if you remember, I just missed to put the slide here, but I have shown this slide of posterior staphyloma ultrasound B scan in your sclera chapter. Just have a look at that. So very, very clearly in the B scan, we can see a posterior staphyloma. Right? So these are the findings of pathological myopia that we have to learn. A few more things which can be associated with pathological myopia needs a mention. High myopia, pathological myopia may be associated with primary open angle glaucoma, right? These patients may be high steroid responders, you know, when the pressures can go very high due to the steroid, right? Then posterior subcapsular cataracts are more common, they're associated with that. And yes, there can be macular hole formation is also more common, right? So these are some other associations as well we have to keep in mind. Otherwise, you just learn the diagram and that's it done. Okay, once you know this, tell me what is break in the Brooks membrane. You just said due to overstretching of the eyeball and the retina is lacquer cracks. What about the break in the Brooks membrane that happens due to collagen disorder? That is what is called angioid streaks. Okay, so this is also break in Brooks membrane, but this time it is due to collagen disorders. We learn its etiology by a very famous and known mnemonic, that is Pepsi. These are the causes of angioid. First is pseudoxanthoma elasticum. E for Ehlers-Danlos syndrome. Another P is Paget's disease. S stands for sickle cell disease, sickle cell anemia, and I is incontinenta pigmenta. Now what we will ask you is the most common cause, and you have to answer angioid streaks. Of most common cause of angioid streaks, we'll answer pseudoxanthoma elasticum. Okay, so we answer most common is pseudoxanthoma elasticum. And any rupture of Brooks, I've just told you when I was talking about lateral cracks, is a very big risk of causing choroidal neovascularization. Right? So these will rupture, because what happens, these are just slight breaks or cracks. These cracks, when they rupture, they will lead to choroidal neovascularization. Okay? Yeah. We come to the next very important macular disorder, with the heading age-related macular degeneration. So when we talk about age-related, we mean to say in old age there are degenerative changes at the macula causing irreversible loss of vision. Okay, so these are degenerative changes at macula leading to irreversible loss of vision. Right. Generally, it starts from 6th decade. Right? So, first of all, you also have to understand, when we say ARMD, it is not a retinal disease. We are talking about choroidal pathology. So keep in mind, this is a choroidal disease. Now, we can classify this ARMD into dry or wet. So this is the most commonly used terms are dry. Non-exudative, wet is exudative, but generally we use the term dry and wet. So we write here dry ARMD and wet ARMD. We are saying these are degenerative change at the macula. Be alert, learn with me. Which is more common? Most common is this one. 85% of the cases, it's not exact percentage, so I'm not writing, so don't note it, but majority of the cases, most common is dry ARMD. Okay, we are going to learn two main features in each. For dry ARMD, the first feature is dried up deposits at the macula, and these are what are called drusen's. Isn't it? So first feature is drusen's, and later it can lead to atrophy at the macula, which is geographical atrophy. Because it's amoeboid in shape, we call it geographical atrophy. So these are the drusen's on the macula, which is a feature of dry ARMD. And later it can lead to atrophy, which is geographical atrophy or dry ARMD. Come to the wet ARMD. First feature will be retinal pigment epithelium detachment. Are we alert here? We are not saying retinal detachment. I am not saying separation of RP from neurosensory. I am saying retinal pigment epithelium is detached from the Brooks membrane. Got it? You remember the layers? This is subretinal space. These are the different layers, and this is your anterior segment, right? So we are saying it is retinal pigment epithelium detachment. And second feature, note down, choroidal neovascularization. So keep seeing this diagram. New vessels to the choroid is, there are new vessels in the choroid, and it slowly percolates into the subretinal space. Hence, the choroidal neovascularization is also called subretinal neovascularization. We also call it subretinal neovascularization. Got it? Which was retinal was here. We talked about that in DR, diabetic retinopathy and so on. But we are saying subretinal, that means it is primarily choroidal. Right? So this is a choroidal neovascular. Choroidal neovascular membrane at the macula. Subretinal neovascularization. Okay, now we talk about investigation. Give the next heading, investigation. In investigation, if I am talking about OCT, what you are going to get in a dry ARMD and what you are going to get in a wet. In the wet, I told you there is RP detachment. So OCT findings are very, very clear. It is the retinal pigment epithelium which is detached as shown here. Okay, so in wet we get RPE detachment. Right? Can we see this? The red line, the lowermost is the RP, it is detached. Okay. And what do you see in the dry RMD are these. What do you call them? In the outer nuclear layer, these are, because it's a choroidal, outer layers of the retina will be involved. Think like this. So these are called your retinal tubulations, outer retinal tubulations. So outer retinal tubulations are particularly seen in dry ARMD. Okay. Come to the next investigation, number 2. The second investigation, of course, is angiography. Right. So on fluorescein angiography, if I'm doing for fluorescein angiography, what I see in wet is, of course, the choroidal neovascular membrane. We describe it as generally what you call it, lacy pattern. But if I am talking about dry, instead of doing a fluorescein angiography, I am going to go for fundus autofluorescence. What is autofluorescence? Autofluorescence means I am not putting the dye and just seeing it to find out the fluorescent property of some conditions like drusense. So drusense, any lipofuscin deposition has autofluorescence property. So you can see in the same way as you're doing any angiography through the blue filter and then you see this fluorescence, but only thing is I am not using any dye. Okay, so this is in dry RMD, the drusense can show the property of autofluorescence. We also have to remember one very important question which we have taught earlier also, that if it is occult choroidal neovascularization, I'm talking about in wet ARMD in fluorescein angiography, if it is occult means generally it is not that. Classical is very lacy pattern classic, which is obvious, but if it is occult we are not able to find it out. What is the way to do it? ICG angiography. So don't forget to mention this in investigation, that I'm going to prefer ICG angiography for this. Okay, this was about the investigation part. I'm again repeating, if you're confused, for dry RMD I will do autofluorescence. I can see the drusense which has quality of autofluorescence. For wet RMD I'll do the fundus fluorescein angiography, and more preferably I will go for ICG angiography, indocyanine green angiography. I think now it's clear. I will be able to see both if it is obvious classical pattern or an occult CN. Too many details again not required at your level, so we will just know this much. Coming to treatment part. So when first very important part is prophylaxis, we'll discuss that before going to the treatment. So when you talk about the prophylaxis, it has been found in the newer studies that if I am giving antioxidants, you have to know the composition of these. This antioxidants containing lutein, zeaxanthin. What are lutein and zeaxanthin? They are natural carotenoids in your outer plexiform layer. So these are, they should be present, okay, in your supplements that you're taking. Okay, so apart from lutein, zeaxanthin, we have vitamin C, vitamin E, okay, zinc and copper. Right? So this is what these are the main constituents. We don't need to learn the strength of each, so I'm not mentioning it, but these are the constituents that our supplement should have to prevent. But again, it is not 100% proof that if you start eating these antioxidants today, you will not get ARMD. But yes, this is in our hand. It may slow the progress or it may be effective in some patients. Apart from that, of course, stop smoking, avoid sunlight. Okay, so sunlight exposure is avoided. For prophylaxis, a few more points: avoid sunlight, direct sunlight, and stop smoking. Smoking is harmful for every part of your body. It does a havoc on the eyes. I hope you all are careful, right? Yeah. So this is about prophylaxis. Now we talk about treatment. When you say treatment, Okay, one more thing. In angiography of you, in dry RMD also, are you going to get something? Apart from autofluorescence, if I do in dry RMD fluorescein angiography, I may see RP window defect. Let's not forget that. So, RP defects may be seen. So, one of this finding, you can just note it down. Right? So, we talked about treatment of first dry RMD. For dry RMD, because there is no effective treatment, first of all, we have to know this. We can't do much about this. What we can help is, of course, monitoring with Amsler grid all the time. And second that you can go for is low visual aids. I've talked about low visual aids. They are generally magnifying images, right? So, low vision aids. One important point, never photocoagulate the drusen. It is going to aggravate the disease. Okay, don't put laser on the drusen. It aggravates the disease. Coming to wet ARMD. Again, wet ARMD, how will I treat will depend on location of the neovascular membrane. So, either it is, this neovascular membrane is extrafoveal, or it is juxtafoveal, or it is subfoveal. So, these are the three locations. When do you call it extrafoveal? More than 200 microns from center of fovea. No, from, foveal avascular zone. From foveal avascular zone. And what do you call it? Juxtafoveal? Less than, beside. Juxta is beside. Less than 200 microns from foveal avascular zone. And subfoveal is below the fovea. It is below the fovea. So, all of you, if it is extrafoveal, I am not worried. I just mentioned this, that I can use my photocoagulative laser. It is not going to damage the fovea. So, here I am going to do a laser photocoagulation therapy to damage this neovascular membrane. But if it is so near, I cannot go for this option. And hence comes the role of, very important, intravitreal anti-VEGF injections, right? And second, of course, is PDT, which I have already explained you, this photodynamic therapy. We are using vertiporphyrin and we are using a diode laser, right? So, vertiporphyrin comes by the name of vuzidyne, and after putting that, after 5 minutes, we are now applying 689 nanometers of diode, and this is done for around 83 seconds. Okay, so this is your PDT. What happens? What does it do? It is actually generating free radical. So, when there is a free radical induction, that will damage the blood vessel, cause thrombus formation. Okay, so this is leading to free radical, write down, free radical induction. All this treatment leads to free radical induction that causes damage of blood vessels and thrombus formation. And therefore, if I am applying it to that neovascular membrane, I will be able to damage that neovascular membrane. Okay? Okay. Now, anti-VEGF agents. When you are talking about anti-VEGF agents, so generally we are giving intravitreal injection, anti-VEGF intravitreal injection. Standard is 0.05 ml of injection is given. Right? Now, you have to be familiar with the names. I think I took few names like bevacizumab, we have written already. This is Avastin. Ranibizumab is Lucentis, and we have talked about aflibercept. A few more. One is your pegatinib. And one more you should know is your broclizumab is the newer one. Okay. So, don't forget the older ones which I have told you. Should I complete the list? It was bevacizumab. This is your Avastin. Let me complete it. Then I told you about ranibizumab. Ranibizumab is your Lucentis. Right? Then we talked about this aflibercept. Anti-VEGF drug, right? So these are, you have to be familiar with the names of these anti-VEGF agents. Primary indication of all these anti-VEGF injections was from AR. It started from ARMD, then it was seen that okay, we can use it for diabetic retinopathy, then it was seen we can use it for your CRVO and other indications. But the prime indication has been always age-related macular degeneration. Right, all of you? Yeah. Okay, so this is the angioid streaks you are looking at with Mr. C. These lines, these are what are angioid streaks. I don't think they will give you angioid streaks in a fundus picture, but still you should be familiar with the picture. Okay, one last macular disorder. What are you looking at here? Can you see hyper, hypo, hyper, hypo? Alternate hyper, hypo is giving the effect of bullseye maculopathy. So you are looking at bullseye maculopathy. Okay, why are you getting this hyper? Due to the pigmentation, melanin. And why am I getting a hypo? Hypo is actually due to RPE damage. Okay. So this alternate, the morphological picture is what is called bullseye maculopathy. They ask you the causes. First, of course, is chloroquine. Second, write down hydroxychloroquine. And third, you will say is cone dystrophy. Okay. Right. So it can be even Leber's amaurosis, or one of your option was Batten-Mayo syndrome. What is this Batten-Mayo syndrome or Batten disease? We call it Batten's disease. This is a cerebromacular degeneration. Cerebromacular degeneration. Right? So these are some of the causes, and you should know what are the causes of bullseye. That's it. And why it is called bullseye maculopathy. Right, all of you? Good. What will be our next heading is fundus dystrophies. Hereditary fundus dystrophies. So the first fundus dystrophy we just said, we'll talk about retinitis pigmentosa. Very, very important topic for you all. Write down, this is a dystrophy of rods and cones. First point. Primarily, it is the rods which are affected, and later stage cone may be affected. Okay. Initially, it is the rods which are affected. Okay. So, second point, it's of course a genetic disease. Most commonly, it is sporadic. Exam question. Now, if it is hereditary, then all three modes of inheritance are possible. That is autosomal dominant, autosomal recessive, and X-linked recessive. Now, autosomal dominant has got best prognosis, and recessive, X-linked recessive has got the worst prognosis. Which one is common is again very debatable. Many sources say autosomal recessive, some say autosomal dominant. I'm in no position to comment. I don't think they will ask you this way. Okay. Then we talk about is rods. Because the rods are affected, now we talk about how this patient will present. So what will be the complaint of the patient? Of course, when rods are affected, we are talking about night vision. So nyctalopia, that is night blindness. Right? What else? Impaired dark adaptation. He will take time to see in the dark. Impaired dark adaptation. On examination, let's talk about on examination. The triad is again an exam question. I hope you're making the cues. What is the triad? Pale waxy disc. If you remember, we have learned this as consecutive optic atrophy. Then, second, after pale waxy disc, attenuated arteries. Attenuation of arteries, and pigmentary disturbance is in form of bony spicules. So the pigmentary disturbance is in form of bony spicules. Let's have a look. This one shows all the features very clearly. This slide. This is what is called pale waxy look. It's a consecutive, means when it is due to retinal disease, there is atrophy, we call it consecutive. These are the bony spicules we are talking about. And this is the attenuation of the arteries, attenuated blood vessels. Okay, so this is the triad of retinitis pigmentosa. It's an exam question. Again, if you look here, this is a slide which is a normal fundus, and here again this is retinitis pigmentosa. We talk about investigation. Investigation, first we will do perimetry. We all should know that a typical disease always involves the mid-periphery first. So it involves the mid-periphery first, right? So what will be the initial finding? Ring scotoma. So initial finding is ring scotoma, exam question. And later, when this disease is spreading anteriorly and posteriorly, what you get is, again this is already mentioned, tunnel vision. What we get here is tunnel vision. So all of you, late stage tunnel vision and early stage ring scotoma, both are cues. What is the second investigation we can do here? Is electroretinogram. Very important. You all know this. There is a decreased amplitude of both A and B waves. Right? But of course first A and then of course B will also become flat. Now, third, I can do an OCT if there is an associated, because if you remember we talked in etiology about the CME. If there is associated CME, this is absolutely, this can be checked with OCT. Then on dark adaptometry, we see that the dark adaptation time is prolonged. This much is enough to know at this level. So it shows prolonged. It is prolonged, right? And later, very late stages, you may get changes in the EOG. Very late stages. Whenever there is a EOG changes, we are talking about retinal pigment epithelium involvement. And you may get a decreased Arden ratio. But it is rare. We generally don't learn at our level. It's more for a PG level. Our level, this is enough. ERG, important, as in the exam. And of course, this is all important as in the exam. These two. Right? Yeah. So next we talk about after investigation is what are the atypical retinitis pigment? Atypical RPs. So when it is away from the typical presentation, we will call it atypical RP. What are the different atypical? Suppose not the whole retina but only a sector is involved, right? If only a sector is involved, this is called sectoral RP. Definitely the visual prognosis here is going to be better. Second, as I told you, it is generally starting from the mid-periphery. Suppose it starts from the center. Then this is called pericentric or inverse RP. Now pericentric or inverse RP, when it starts from the center, which means it is going to this time. In a typical RP, the central vision would be retained till last, but here it is going to be involved early. That is why we call it inverse RP. Then third atypical form could be when bony spicules are absent. It is more like a salt and pepper presentation, but bony spicules are absent. This is called retinitis pigmentosa sign pigmento. So in this, what you see? No bony spicules. Okay. Then fourth is when you have, instead of black salt and pepper situation, what you are getting is white dots, right? Let's make a white dot. No, this one. Yeah. So if there are white dots, now we call it RP albescens. This is another variant, RB albescens. Right? So these are the variants of retinitis pigmentosa. What next we have to learn is systemic associations. Now again, this is debatable, but if they ask you most common systemic association, please answer Usher's. It is Usher syndrome. Usher syndrome is retinitis pigmentosa with deafness. Do you remember deafness with interstitial keratitis was Cogan syndrome, right? Yeah. Now, what can be the other association? Of course, very commonly we learn about this one is Lawrence Moon Bud Beetle syndrome. Lawrence Moon Bardet beetle. Just be familiar with the names. So in this syndrome means many features anyway. Apart from the retinitis pigmentosa, we are getting mental retardation, obesity, polydactyly and paraplegia. I suggest you to learn so much. When you read, you'll just have a little bit of idea. This is enough. Most common is what they have asked you till now. A few more names if you want to know about the seismic association. One is Kern-Sayre syndrome. So when you say Kern-Sayre syndrome, we are talking about retinitis pigmentosa. Along with that, we have your heart blocks, okay, heart disease, heart blocks, and ocular myopathies, that is chronic progressive external ophthalmoplegia. Okay, so this is myopathy, chronic progressive external ophthalmoplegia, or you can just say myopathy, right? So this is your Kern-Sayre. Then one more you have to know is Refsum's disease. This is also another systemic association. You all know this Refsum's disease is mainly defect in the phytanic acid. So this is one where you can manage, there is some treatment, and that is diet with low phytanic acid. So defective phytanic acid metabolism and therefore low phytanic acid diet. Another one is your Konsweek, Basin-Konsweek. Basin-Konsweek is again syndrome. What are the features? Retinitis pigmentosa with acanthocytosis and A-beta lipoproteinemia. Okay, ataxia. These are the features of Basin-Konsweek. And again here we can manage the treatment as low fat diet and vitamin supplements. Right? So if I talk about normal, of course there is not much effective treatment of retinitis pigmentosa, but if you talk about a treatable RPs, we have two in mind. One is Refsum's disease and second will be Basin-Konsweek, where you can do something about it, right? Syndrome. So a rough idea about the different seismic associations. We come to the treatment part. What is the treatment of retinitis pigmentosa? As I said, generally we don't have any effective treatment. What we can do, of course, regular follow-ups to know the situation with your visual fields. I can go for ERG, right? Then we are giving vitamin A because the rods are the responsible, so vitamin A, sometimes even vitamin E as an antioxidant, though it doesn't have much role. Then third, what is important asked in the exam is docosahexaenoic acid. This supplement is given, docosahexaenoic acid supplements. It is actually a normal component of your rods. It is seen that this is less in these patients. So this has helped to decrease the progress of disease. Okay, both vitamin A and docosahexaenoic can decrease the progress of disease. Okay, any other newer therapies? Yes, one is one of the gene defects that has been already localized is RPE65. So if it is an RPE65 gene defect, we can do something about it. Then you can go for gene therapy. So what do you do in this gene therapy? We are giving adenovirus associated vector based gene therapy. This is called adenovirus associated vector based gene therapy. So this vector based this is given as a single dose intraocular suspension. Single dose intraocular suspension of, name of the drug, note down, it is voretigene neparvovec. Okay, so this is Luxturna. So this is the therapy which can be given if your patient has RP65 gene defect. Any other thing, any other newer development or newer therapy for retinitis pigmentosa? You can go for retinal implants, which is of course not available in India, but yes, this is one option, extremely costly. So it is retinal implants, and in retinal implants, so instead the retina where it is not working, it is replacing with that, the impulse is going to the brain and the patient is able to perceive. So name is Argus 2. Just remember the name Argus 2. I don't think they will ask you much here. Only the name is enough. So these are some newer therapies we can try for retinitis pigmentosa. Right? Nothing works. Of course, low visual aids. Low visual aids are there. Right? And of course, as I said, it can even lead to the cone dystrophy. Now, a few points on cone dystrophy. What are the typical feature of cone dystrophy is? Any unexplained decreased central vision. Okay? So, decreased central vision. Write down. Right? Unexplained. With you are getting photophobia. So rest you're finding everything normal, you can't find any defect, but you see the patient has photophobia, his central vision is less, and with nystagmus. Right? That means there is some problem in the cone. This is typical of cone dystrophy. You will see that the fundus, when you are on examination, fundus is normal. You can't find any defect. How do you get it? How do you diagnose it? How do you catch hold of it? I have told you, it is multifocal ERG by multifocal electroretinogram. These are the points, more than enough. Right, all of you? So that was about retinitis pigmentosa. Okay, so before I finish this topic, one small thing more here. What can be some other ocular associations in retinitis pigmentosa? What other diseases generally? I mentioned about CME. So if you want to learn, just in my style, make the diagram. So it can be associated with keratoconus. Okay. It can be associated with PSC, posterior subcapsular cataract. Right. It can be associated with, right here, open angle glaucoma, and in retina you will write here is CME. Right. Now we are over with this. Okay, before I go to the next macular dystrophy, one more thing I would add when I was talking about bullseye maculopathy. So we have just learned the causes of bullseye. Just remember this. They can ask you what is the cumulative dose when the chloroquine will lead to bullseye. It should be more than equal to 300 grams. The cumulative dose we are talking about for this is 300, and for hydroxychloroquine it is 1000 grams. If the cumulative dose is more than this, equal or more than, then it is at a risk of causing bullseye maculopathy. This much is enough. We come to the next macular dystrophy. So the next macular dystrophy we will talk about is Stargardt's disease. So we talk about Stargardt's disease is also called, point number 1, juvenile macular dystrophy. Right? So it is manifesting after the first decade only. What is a variant? The variant is called fundus flavi maculatus. So it is the variant of the same disease. We call it fundus flavi maculatus. Right? So this is one of the most common macular dystrophy. What is the gene involved? You have to learn. When we talk about Stargardt's disease 1, which is most common, and we'll talk about this only. So it is autosomal recessive. ABCR, the gene first, the name of the gene please. ABCA4. Okay. So the name of the gene involved is ABCA4 and it is autosomal recessive. Autosomal recessive. These are important points. So as I said, clinical features, this is going to manifest in young age only, initial decades, right? And vision drops down to 6/60 in the initial stage only. So this patient will be complaining of gradual diminution of central vision very early in life and later it will drop down to 6/60. What else I will see? Apart from decreased central vision, there will be decreased color vision as well, right? Or impaired dark adaptation. So mainly what is this exactly? It is retinitis pigmentosa was what? Dystrophy of rods and cones. But here this is dystrophy of, let's be very clear, of retinal pigment epithelium. So we are now talking about dystrophy of retinal pigment epithelium. Okay? Right. So generally diminution of vision is what complaint, and on examination what we see. Initially we call this mottled appearance. So this is the initial presentation in the fundus changes in the Stargardt's is this is called snail lime appearance. Right? So this is the snail lime appearance, and later what happens? So this is all dystrophic changes in the retinal pigment epithelium in the macular area. Later, can you see this? As if you have beaten a metal. So it becomes something like this. This is called beaten bronze appearance. Hope you are noting down. I am writing here only. So beaten bronze appearance. So these two terms are very important to know in relation to the on examination finding. Next is investigation. Talking about investigation, all of you. First write down is fundus fluorescein angiography. It's an important exam question as well. All of you pay attention to this angiographic picture. White means dye, and you can see the dye in the blood vessels. So we have injected a dye here. What about the background choroid fluorescence? I'm not able to appreciate that. It's a dark background. Why is this happening? Because of a dense deposition of lipofuscin on the retinal pigment epithelium. And because the background fluorescence is not seen, no background choroidal fluorescence seen. Right? Because it is not seen, we call it dark choroid sign. Or we also call it silent choroid. You should be familiar with these terms. Right? This is angiographic finding. Why are you getting here some hyperfluorescence and is there no lipofuscin deposition here? So that you can understand there can be damage to the retinal pigment epithelium and therefore you can see some dye there. Then we talk about, look at this one. What is this investigation? Write down, this is number 2. Look at the blood vessels. Do you see any dye? No. So what are we looking at? We haven't put any dye. We are talking about fundus autofluorescence. AF is fundus autofluorescence, and you will see here that all these lipofuscin deposits are shining. This is what is called fundus autofluorescence. Right? So this is again very typical of this condition wherever there is lipofuscin deposition. Okay. Then we talk about also we need to mention, are there going to be changes in EOG? Definitely it's a RPE dystrophy. Whenever there is an RPE defect, you get decreased EOG is abnormal. And later on in late stages, it may affect the ERG. In late stages, may affect the ERG. Right? And mainly which ERG is abnormal? Photopic. With the bright light when you see, that is the photopic ERG, which you will see is subnormal. Okay, so this is Stargardt's, and what is the treatment now? So treatment, again, avoid bright sunlight, number 1, right? So we generally ask the patient to avoid any light exposure, right? So sunglasses can help. Nothing much can be done otherwise. Should we give vitamin A? Now this is an important point. Should we go for vitamin A? No. So write down avoid vitamin A. Don't keep giving vitamin A everywhere thinking that okay, it is helping. Why you avoid? Because this actually promotes lipofuscinosis. It promotes lipofuscinosis. So don't give vitamin A. Right. So which is the next dystrophy? We will say the next is Best vitelliform. Best disease. Best is a name, okay? It's not a best disease. So this is Best vitelliform macular dystrophy. So give the next heading Best vitelliform macular dystrophy. Again, it is dystrophy of retinal pigment epithelium. Again, it's a childhood disease. Autosomal dominant. What is the gene involved? It's a genetic disease, and what is the gene involved? Is bestrophin gene. We will say it is bestrophin gene. Okay? Now, once we know this much, how will this patient present? So, initial presentation, the vision is still sustained. So, initially we have normal vision. It is only in the late stage that vision drops down. This is important difference. Vision will become less than equal to 6/60, but that is in the late stage. So, let's see how this is progressing. Of course, initially only the patient is going to complain of some diminution of vision. So, the clinical features we learn in stages. First stage is pre-vitelliform stage. So, when you say pre-vitelliform stage, you see that, okay, the fundus, you don't find anything there. Even vision is looking normal. But what is abnormal is electrooculogram. So, normal vision, right? Normal fundus, but what is abnormal is, and I told you earlier also that abnormal or decreased electrooculogram or decreased Arden ratio, this is more diagnostic for Best disease. This is your pre-vitelliform stage, and then second comes your vitelliform. What is vitelliform stage? Is when the lipofuscin is now collected in a typical egg yolk appearance. This is what is vitelliform stage. I am writing here. So, vitelliform stage is, this is what? Again, nothing but lipofuscin. Right? If I do an autofluorescence test, it is going to autofluorescence. So, this is your egg yolk appearance. You have to be familiar with the term egg yolk appearance. After vitelliform stage, we have next is pseudo-hypopyon stage. This stage is called, third stage, write down, please write down, pseudo-hypopyon stage. What is this? As you see, there is a partial reabsorption and collection of this lipofuscin because of break in the retinal pigment epithelium is breaking. What is happening? It starts collecting in the subretinal space. We all remember, na? Retinal pigment epithelium, then comes your subretinal space. So, this is in the subretinal space. Again, what it is nothing but lipofuscin due to break of retinal pigment epithelium. Right? So, this is pseudo-hypopyon stage. After pseudo-hypopyon comes the fourth stage, and this one is called vitelliruptive. Vitelliruptive stage is a stage where the vision is now going to drop down. Right? And after that, the last stage is your atrophic stage. So, this is what is called, this appearance is called scrambled egg appearance. That was egg yolk, now it is called scrambled egg appearance. And the last stage, note down, is atrophic stage. So, this is what is Best disease, atrophic stage. What was the EOG Arden value I told you? Less than 1.5. So, investigation, definitely diagnostic is electrooculogram. Right? So, what will be the complication of Best's disease? It can complicate as choroidal neovascularization. Once there is atrophic state, there can be choroidal neovascularization. Right? Now, investigation. First, we will of course mention EOG, where Arden ratio is less than 1.5. Right? Then we will talk about autofluorescence. We see there is hyperfluorescence or hyperfluorescence is seen in the egg yolk area, from the egg, because this is lipofuscin. We can do angiography also, and generally autofluorescence and EOG is most helpful, right? We can go for an angiography and see which area is hypo and hyper. But you're not going to get the same, the same picture as in Stargardt's, that you're getting a dark. Stargardt's, please remember the dark choroid sign. And do we have, this is Best Vitelliform is mainly a childhood disease. We also have an adult form which is called adult onset foveal vitelliform dystrophy. Just know it, that there is one adult form also. That is enough. Right? So that was about Best disease or Best vitelliform dystrophy. Let's talk about retinal detachment. What did we discuss? Retinal detachment is separation of retinal pigment epithelium from neurosensory retina. So let us define it. It is the separation of retinal pigment epithelium from neurosensory retina. Right? Simple? Okay. What are the types of retinal detachment? Types of retinal detachment, there are 3 types. One is your rhegmatogenous. Second, write down tractional retinal detachment. And third is exudative. When you say rhegmatogenous, one by one, first is rhegmatogenous. Rhegmatogenous, what do you mean by that? So rhegma means break. Okay. So rhegma is break in the retina. So this break in the retina, so we are discussing how this is happening, can either be a tear or a hole. Okay, so this is how it is created. So when you say tear, this is due to traction, right? Tear is due to traction, and as a rule it is always horseshoe shaped. Tear is horseshoe shaped. Whereas when you say hole, any degenerative change can degenerate and lead to hole formation. So hole is after degeneration. Right? What can be the most common cause of traction? So in old age, when the vitreous collapses anteriorly, what do you call that? Posterior vitreous detachment. So most common cause of this traction leading to this rhegma formation is PVD. This is your posterior vitreous detachment. Right? Okay. Then they have asked you another question. Which are the degenerations which are prone to and to lead to hole formation? So which are the degenerations which are dangerous and can lead to hole formation? We are going to learn 2. One is lattice degeneration. These names are all based on the morphological appearance. So lattice degeneration and snail track degeneration. Lattice and snail track degeneration. Right? Okay. So once we know this, second was so that is rhegma. So what is happening? Can we think together? Any kind of break in the continuity of the retina, go to your first diagram, the water is going to enter from the vitreous into the subretinal space, and when it enters the subretinal space, that leads to, so when the water reaches the subretinal space, that will again cause retinal detachment. This is your rhegmatogenous retinal detachment. Okay. And how do you get an exudative retinal detachment? Exudative means there is some exudation. What can be the cause of exudative? Exudative means if this is the retinal pigment epithelium, there is some exudation from the choroid which is going into this subretinal space, and this is causing retinal detachment. So this is the neurosensory retina. I hope you remember this diagram, right? So this is any cause in the choroid which is causing accumulation of fluid in this subretinal space and leading to retinal detachment is exudative retinal detachment, right? So exudative, we can think of few causes of exudative. It could be just an inflammatory cause, like inflammatory cause, for example, in cases of scleritis, right? Posterior scleritis, that could be one cause, right? It could even be due to vascular cause like CSR, or there is any neoplasm, tumor, neovascularization. All this can lead to exudative. And also we should also keep in mind some seismic causes. Seismic cause you can note down is pregnancy induced hypertension, very important. for you all, right? Our renal hypertension or PIH. Just remember these two. Okay, so this could be systemic. So just remember, if I want you to put it in a crux, any neovascularization, any tumor, any pathology in the choroid which percolates into the subretinal space and causes the retinal detachment is what? Exudative retinal detachment. Okay. Now we talk about traction. Traction we all know so well. When there is retinitis proliferans, that is called neovascularization in the vitreous. The new vessels with the fibrous tissue will contract, pull the retina, leading to traction. We have done this, so that is your traction. Now, which is the most common is your exam question? Let us note down. Most common type of RD is rhegmatogenous, because even tractional can lead to rhegmatogenous, right? Most common type of retinal detachment you will answer is rhegmatogenous. Okay, so what are the clinical features if this patient is suffering from retinal detachment? Let us think ourselves what will happen. Do you realize first thing is your diminution of vision, especially if the central retina is involved, definitely. If it is the peripheral retina, what are we getting? Visual field defects. Think with me. If your superior retina is detached, what type of defect are you going to get? It is inferior field defect and vice versa. What else I can get when you talk about retinal detachment? Especially in case of, so this is overall I am giving you the picture, but especially for rhegmatogenous, it is said a curtain is falling in front of the eye. Okay, so curtain falling in front of eyes, especially for, is the history given by the patient, and this is more in relation to the rhegmatogenous. So something like this. So the patient is reading and it can feel this diminution, as if the curtain is coming in front of the eye. Okay. What are the other features apart from this? The patient will complain of floaters. Everybody knows what is floaters? Floaters are opacities in the vitreous cavity. Okay, opacities in vitreous cavity. So the patient complains that something is moving in front of my eye. These are nothing but floaters. Then next is your photopsia. What is photopsia? Photopsia is flash of light seen by the patient. In the field, there is a flash of light, either at the peripheral field or somewhere in the center. Generally, it is at the periphery actually. This flash of light is photopsia. Why is it happening? It is due to, write down, traction on rods and cones. It is due to traction on rods and cones. On the photoreceptors, you get photopsia. And what else? Gray reflex. What is the actual color of retina? It is not red. It looks red because of choroid, because choroid is very vascular. Actual color of the retina is grayish one. So when it is detached, we can appreciate that, and this is what is called gray reflex, when the redness is less. Okay. Then we talk about on-examination findings. On examination, what are the things you have to keep in mind? We first take into account rhegmatogenous. How does it look like? What are the points we have to remember for rhegmatogenous retinal detachment? Since it's a rhegmatogenous retinal detachment, first is it will have when you look at the retina, it has a corrugated appearance. We describe it as corrugated appearance. A very slight mobility, which is called undulating. Okay. You will get both floaters are present because of the opacity of these dispersion of pigments due to the retinal break formation. The pigment can disperse into the vitreous, leading to floaters. So floaters is one feature. Second, write down, you will get photopsia also in this case. This is more of a symptom than a sign, of course. I'm just mentioning it here. Right? And very important, too many pigments in the vitreous. This is what is called tobacco dust or Schaffer's sign. It's an exam question, all of you. What is Schaffer's sign? Pigment dispersed in the vitreous cavity. Okay, so make a cue here. This is also called tobacco dust. It is a sure sign that there is a retinal break. If you are not able to locate a retinal break, please do more of the indirect ophthalmoscopy to find out where the break is. Right? So, this is what is Schaffer's sign, which is a sure shot indication that we have a retinal break. Suppose there is difficulty in finding the retinal break, be familiar with the term what is Linkoff rules. Linkoff rule mainly is applicable for fresh rhegmatogenous retinal detachment, right? And it is all based, just know the term at your level. We don't need to have a lot of details here. But when you apply the Linkoff rule, which is governed by what are the factors? So first factor is your gravity. And second, of course, the subretinal fluid, apart from settling downwards, will also be limited by anatomical landmarks, isn't it? And what are the anatomical landmarks we have to keep in mind in order to think is, one is your optic nerve and then second ora serrata, right? So very, very important point here. This was asked in one of your options. Rhegmatogenous extends till ora serrata. Of course, not after that. Extends till ora serrata, right? So this is one difference with the choroidal detachment, which can extend up to the ciliary body. Right. So when you're trying to understand Linkoff rule, for example, there is one small, very simple example for you to understand. Suppose it says that if you are seeing a retinal detachment, right? If you're seeing a retinal detachment where the both side detached retina are at the same level, right? If this is the optic disc and both side detached retina are at the same level, right? Then the break has to be at 6 o'clock position. So this way we are trying to find the break. Then this will be the break. If both the retina, just one. This will also be at the same level, right? So if both the subretinal fluid in the both sides of the retinal detachment are at the same level, like this, then the break is at 6 o'clock position. I'm just giving you an idea of how Linkoff rule helps. No details have ever been asked, so we may not bother ourselves. Right. So these are the features of rhegmatogenous. So you have to learn the term Schaffer's sign, Linkoff rule, and remember it can extend till ora serrata. Both floaters and photopsia are present. We come to the next one. What is the next feature? I'll show you the slides shortly. The next will be your tractional retinal. What are the features of a tractional retinal detachment? Typically, this is concave. You will see the traction bands and it is almost immobile. Due to the traction of rods and cones, you may see photopsia may be a feature, but floaters are not present. Okay? So, photopsia is a feature, but floaters may not be present. This is about tractional retinal detachment. Coming to next is your exudative. Exudative retinal detachment typically is a convex RD and this is mainly very, very mobile. Why? Because the subretinal fluid will move according to the position of your head. So we call it as a mobile retinal detachment where this is happening because of shifting fluid. Okay, we call it shifting fluid. So this is an important feature. We put a Q here. Right? Second important thing is when this fluid is reabsorbed from the subretinal space, we get some pigmented areas which are called, these subretinal pigments are called leopard spots. So another term here, leopard spots. What of the photopsia and floaters? You can see floaters, of course, especially due to inflammatory cause, but generally no photopsia. Okay, these are the features of your exudative retinal detachment. Let's see the clinical slide, all of you. So this is curtain falling in front of the eye. Here you go. This is the gray reflex you can appreciate. This is your detached retina and this is the typical horseshoe shaped break that you see. When you look at this one, this is your convex. This is exudative retinal detachment. These are the traction bands. These are the traction bands. Right? So we are here looking at this gray reflex. This is normal, red reflex. This part is all detached and this is more concave. So this is your tractional retinal detachment. Right? Again, here you are seeing this horseshoe shaped tear. And any old RD can be seen as separation of detached and attached retina Due to some cell proliferation, these lines can be seen, which is called demarcation line. Can we note down this, please? Demarcation line is a sign of old RD. Just remember, it is a sign of old RD. And now what you are looking at, this is your OCT indicating retinal detachment, right? This is the retinal pigment epithelium. Separation is called RD, and you can even see the cystoid spaces filled with fluid, which is, so there is also CME, right? Or intraretinal. It's not CME when you say CME when it is at the macular area. This is more intraretinal edema. I think this is a better way to describe it. Yes, right? Okay. Then we talk about, once you know what is RD, what are the types. So we learned what is RD, what are the types of RD, what are the features of different RD, how they look like. Talking about the management, that is the treatment of retinal detachment, right? So treatment, first we take is rhegmatogenous retinal detachment. So rhegmatogenous retinal detachment, first question is, what is the aim of your treatment? Aim of the treatment is to close the break. Common sense, है ना? So to close the break, once the break will be closed, the fluid is reabsorbed and the retina will be reposed. Now when you say to close the break, how are we going to do that? This is important and we have to understand. So you all should know and be familiar with what is Day's procedure. What is Day's procedure? D stands for drainage. Okay. So first of all is whatever fluid, subretinal fluid, especially in the OLRD. So we have to, and especially if it is difficult to locate the break, we have to drain. So drainage. A here stands for air injection, air in the vitreous. This is your A. C stands for then cryo the break area. And finally E is encirclement band. Now I think you all must be lost. What is this? So let us understand in a very different and in my style, what are we talking about? Right. So first of all, suppose this is your retina with a break. This is the retina with a break. Outside this is choroid. Outside that is sclera. Very simple. Right? And this is your anterior segment. Correct? Now retina is a very sensitive tissue. You cannot just hold and stitch it. So how do you close this break is, suppose we are putting cryo corresponding to the location of this break on the sclera. And the temperature of this cryo probe is around -72 degrees centigrade. With the freeze thaw method, what is happening? This will seal. Right? Now, if suppose the position of the retina is somewhere here because of the collection of the fluid, what you are doing? You are draining the fluid. You are injecting air in the vitreous to repose the retina back here, and then you are doing cryo to seal this. Easy? Now, once you have done this, if I just leave it like that, with my eye movement, it can reopen. So what next I have to do is, I will aim to indent, let me make the other diagram to explain. Same thing, retina, choroid and sclera, right? I said we are putting cryo here corresponding to the break. So what I am trying to tell you here is, just sealing the break is not a solution. It will reopen. So what next thing is, do one thing, little bit internally indent it. When you are indenting it, what you are doing, you are putting the seal point out here. When you put the seal point here, now it will not reopen. How to indent that? I have one thing in hand. I will bring two far points of the sclera a little closer, which is called buckling of sclera. When I buckle the sclera here, I internally indent the retina out here. Got it? So this buckling is what is, we say scleral buckling. Now this scleral buckling, either you put radial if you are just concerned with one break. But suppose there are multiple breaks. Then you are putting the whole encirclement band around. Let me show you, you'll understand. Have a look here. So this scleral buckle is like an encirclement band around the whole. This is what is called encirclement band. Right? This is the encirclement band. Or sometimes you can just have a radial buckle like this. Sometimes it is like this, or sometimes you can have a radial buckle only this much. So either it is radial or as shown here, it can be an encirclement band. So why are you doing it? I think you are now very, very clear. We want to indent the retina so that the sealed point is not opening. So that is what we do in case of management of rhegmatogenous retinal detachment. Right? Okay. One more important thing that needs a mention here is, suppose the break is present on the superior quadrant, only superior 8 o'clock position, then, and I don't want to go for RD surgery, then another option for this rhegmatogenous retinal detachment, please note it down, can be pneumatic retinopexy. We will have some idea about this. What is pneumatic retinopexy? What we are doing here, okay, first understand for me. So what we are trying to do, there is an RD at the superior quadrant, there is a break and there is your retinal detachment, right? You want to close the break, it is in the superior quadrant. What we are trying to do is, we are injecting a gas which will rise up, cause a tamponade to close that break and therefore the resolution of the retinal detachment. So this can be possible when the patient has this break only on the superior quadrant, of course, because positioning after that is very important. The patient has to be always in an erect position so that the gas can cause the tamponade, right? Now imagine yourself, anything in the inferior quadrant, you cannot be standing upside down. So that is not possible in inferior quadrant breaks. So what you have done here, you used a gas bubble, right? So this gas bubble is expanding, it is expansile, right? And it is actually causing this pressure on the retinal tear and it is trying to seal it through this, right? So this is what is your pneumatic retinopexy. And slowly, as you know, it will be reabsorbed after the definite interval of time. As I just mentioned, NSF6, it is 2 weeks, and if I am using C3F8, it is 2 months. Okay, so this is what is, so what you are doing, intravitreal gas injection, then you are doing a cryo or laser, and then of course gas is not enough, please, when you are putting the gas, you are just reposing this, right? Then to seal the break, you are using cryo, and when you use a cryo and seal the break, and then this is maintaining the tamponade and therefore the retina is healed. Yeah. So these are the steps for pneumatic retinopexy. Either I do cryo or laser and appropriate head positioning. These 3 things are important. Gas injection, cryo, appropriate head positioning. Hope now it is clear. Yeah. So this was about your retinal detachment. One more important point which needs a mention here. If you are going for a pneumatic retinopexy, these gases are expansile, right? So you should not go for any air travel. Because in low pressures, this gas can expand so much, it can actually block the central retinal artery and the patient can have CRAO. Okay, so no air travels allowed if you are, this is important because these days this is the commonest mode of traveling. So no air travels because this is expansile, the gas expands, and when the gas expands, it can lead to risk of central retinal artery occlusion. Okay, yeah, that was about retinal detachment. What are you seeing in this slide is pars plana vitrectomy. If there is a vitreous hemorrhage, there are traction bands, then you have to remove it through pars plana vitrectomy. And whenever you are doing this pars plana vitrectomy, then you will have to put some vitreous substitutes. I'll talk about vitreous substitutes. Questions are asked here, but after a while. What was the second type of retinal detachment? Second type is your tractional retinal detachment. Now, tractional retinal detachment, again, let us think logically. If it is already the traction bands are formed, you have to cut the traction bands, right, and repose the retina. This is what you will do. Prognosis is not very good, and repose the retina. So that will lead your pars plana vitrectomy to cut the traction bands, and of course, then we can again the role of vitreous substitutes out here. We come to the third. Third is your exudative, and of course the cause. What is the cause of tractional retinal detachment? Is retinitis proliferans. So let's not forget, we may have to go for PRP. Let's mention this first. Cut the traction bands, repose is one thing, or we have to go for PRP or surgery. So ultimately your treatment is pan-retinal photocoagulation, or we have discussed so much in length about anti-VEGF injections. So that is to remove the basic cause. The cause is mainly hypoxia, and how we have discussed all this in our vascular diseases of retina. Now coming to exudative retinal detachment. Exudative, again you have just discussed the causes with me. Do you remember? Should I remind? So we were talking about uncontrolled hypertension. We were talking about scleritis, any inflammatory condition like scleritis, right? So in all these cases, or CSR, so in all these cases, what CSR itself is exudative only, retinal detachment. So what is the treatment here? We have to remove the cause. So treatment is treat the cause. So what is the treatment? Treat the cause. Remember this. This is enough. We can think one by one. What is the basic cause? Once you treat the cause, any tumor, any exudation, any neovascularization, you will be able to manage the exudative retinal detachment. So we all know that ultimately, what about vitreous substitutes? Vitreous substitutes can be of two types. Let's note it down. Either we can use a gas or we can use liquid. When you say gas can be air, but this collapses within 5 days. So you can just divide it as gas, non-expansile and expansile. In non-expansile, we will learn air, one option, right? Or it could be helium. Generally, air is commonly, if we use air here. Second is your expansile type, which is more broadly used these days. In expansile type, very important is SF6, sulfur hexafluoride, right? So this will be reabsorbed. So this is mainly stays still at least 2 weeks. You have to understand this, right? So whereas then second type you will say C2F6 and third is your C3F8 perfluorocarbon. These perfluorocarbons, which is the best? You will say this one is the best one. It can stay till 2 months and then it is reabsorbed by 2 months. Okay, so we need 100% concentration of either SF6 or C3F8 or C2. SF6 has been your cue, and which is the best vitreous substitute they have asked you? You can answer this, C3F8, right? So that was your gaseous form. Then what about liquids? We all know about silicone oil. So liquids, first is your silicone oil, and second you will again learn perfluorocarbon liquid. So one is silicone oil and next is PFCl, this is perfluorocarbon liquids. Okay? Silicone oil, you have to go for a second sitting because it should be removed after 3 months, right? So you have to go for a removal surgery after 3 months. That is one disadvantage because this is not self-absorbing. You will again have to take the patient to operation theatre. Another important thing, and what are the other problems that silicone can lead to? One important point here, please, and that is it can also cause band-shaped keratopathy. It can lead to band-shaped keratopathy. And very important complication, sometimes silicone can leak in the anterior chamber. Let us see here. Any pus in the anterior chamber, what do you call it? Hypopion. Where is the hypopion? Down here, right? If you want to make this diagram, you can make it this way also to understand that hypopion will be here, right? But if it is silicone, suppose you have done an RD surgery and after your vitrectomy and doing the retinal detachment surgery, when you're putting a vitreous substitute, you have put silicone oil. So in some patients, what happens? It leaks in anteriorly. Oil is lighter than water. So now this time, this is seen on the upper part of the anterior chamber like this, right? So this, you see it on the upper part, this is what is called inverse hypopion. Important for exams. It is also known as hyperleon. We call it hyperleon, right? So inverse hypopion or hyperleon. Make a cue there, all of you. Let's have a look. So this is how you see. This is the silicone oil in the anterior chamber. This is your hyperleon. So these are some of the problems of using silicone oil, right? So in heavy liquids, if I would prefer PFCl, perfluorocarbon liquid. We come to the last topic of this chapter, and that is retinoblastoma. A very, very important topic for exams. All of you give the heading, retinoblastoma. So retinoblastoma, we all know, is the most common. This we have mentioned in the orbit chapter also, that is the most common primary intraocular malignancy of children. Right? So it develops from, so retina is developing from neuroectoderm. So this is from the immature neuroectodermal cells. These are called retinoblasts. So it develops from retinoblasts, which are neuroectodermal in origin. Right? Okay, so this tumor of the retina, how does it manifest? What are the clinical features? So first thing they will ask you here is, this is exam question, but please put a Q there. Then what is the most common age of presentation? So the most common age we will answer is 18 months. So it is common within 3 years, both are true, but commonest 18 months. So if 18 months are given in the option, we have to mark this. If 3 years is given and 18 months is not given, then we mark 3 years. Got it? So number 1. Number 2, they will ask you, this has also been a Q, most common mode of presentation. Most common mode of presentation we all know is the white eye reflex, which is called leukocoria. Leuko is white, coria is pupil. So have a look, this is what is white eye. Normally this should be the normal reflex in the right eye of this child, but this is what is white eye reflex or leukocoria. Coria is pupil. Okay. And this is the retinoblastoma, that is the tumor in the retina. This is your retinoblastoma. Next point, and also exam question, that which is the second most common mode of presentation. So second most common mode of presentation you will say is squint or strabismus. Right? Then what else? What are the other ways it can present? So this is also exam question, that retinoblastoma can present with all except. So you should know the various ways it can present. It will present as glaucoma because the pressures will rise. It can just present as what is pseudo-uveitis, which means you see KPs, but actually these are not KPs, but these are not inflammatory cells or pigments, but they are mainly tumor cells, which is called pseudo-uveitis. Similarly, there is a term pseudo-hypopyon. Again, pseudo-hypopyon means these are not pus cells, these are again tumor cells, not pus cells. Then it can also present as orbital cellulitis. These are the various ways it can present. Right? Okay, so once we know this, we have to also think about what can be the differential diagnosis of leukocoria or white eye reflex. This is again important for you all. You all must have done this in the MBBS level, right? So first of course is congenital cataract. So apart from retinoblastoma, what are the other causes I'm talking about? I'm not mentioning retinoblastoma here. So congenital cataract. Then can you think yourself, a child of 3 years old, what can be shining as a white eye reflex? We are thinking of the DD this way. So you can say cyclitic membranes. We have learned this in uveitis. It could be fungal endophthalmitis, right? Then it could be central choroiditis. What is the cause of central choroiditis in children mainly? We will say toxocariasis. So central choroiditis, mainly toxocariasis. Okay. Then next we will learn is number 5 is central colobomas. This is again embryological disorder where a part is not formed. So if that part retina choroid not formed, what do you see? Do you see the patch of sclera? So central coloboma can also be a cause of white eye reflex. Then some retinal diseases like retinopathy of prematurity. We have learnt about psychiatrical ROP. Then Coats disease, which is nothing but in small male children. This is multiple microaneurysms, right? And of course the sequence is same as explained to you all in retinitis proliferans. So this is Coats disease. Then persistent hyperplastic primary vitreous. We'll talk about it in vitreous chapter. Persistent hyperplastic primary vitreous, right? And of course retinal dysplasias, when the retina is not formed properly. One more if you want to note down, central retinal detachment, the grey reflex seen centrally is also can be a cause of white eye reflex. All these causes together, leaving aside retinoblastoma, are collectively called pseudogliomas. All the 1, 2, 10 that you've learned are collectively known as pseudogliomas. Most common cause, we will answer congenital cataract. Right? Okay. Next we talk about, we should also know that if this is the retina and this is the vitreous, this is your choroid, right? So any tumor which is going towards the vitreous, this is your endophytic tumor, and going towards the choroid, this one is your exophytic tumor. Exophytic tumor. Okay. We should know what is exophytic. Can you understand this? So if the tumor is growing towards the choroid, this becomes your exophytic. And when it is growing towards the vitreous, it is endophytic. Then we talk about, once we know this, next heading is investigation. You know how it is diagnosed first? This is ours in the exam. The first diagnosis generally is ultrasound B scan. We can also go for CT scan. So what do you see in the B scan? First of all, what do we see in the B scan is this. Looking at the B scan, this is the tumor that is seen, and it calcifies. It can be a cause of intraocular calcifications. Right? So this is the tumor. This is a picture of ultrasound B scan. This is retinoblastoma. Second, I said was CT scan, which helps us to also see the intracranial extensions. Third, we can go for MRI. MRI helps us to also check for associated pneumonias. So the next investigation, this is the fourth investigation, is X-ray Rees view. So X-ray Rees view, what is Rees view showing you? The optic foramen. So what is this optic foramen? Why are we looking at this optic foramen? We all remember the optic foramen. It is the optic nerve and ophthalmic artery which are passing through the foramen. So let us draw here, this is the orbit and this is your eyeball, optic nerve, optic disc and optic nerve. We all know it will pass through the optic canal. This is your intracanalicular part of the nerve. Now, if this is the tumor, most common mode of spread is through the optic nerve. This is one question. And therefore, when it reaches this intracanalicular part of the optic nerve, what will happen? It will eat the bone, and what do you get? Is enlargement of optic foramen. So this is why we are looking at the optic foramen and Rees view. What are we trying to see? We are trying to see the enlargement of optic foramen through Rees view. Okay. So this is also as an exam. It's important. So X-ray Rees view is another investigation for retinoblastoma. And lastly, and of course this question, that what is the most common mode of spread? We will answer the most common mode of spread is through optic nerve. Right? Coming to number 5. Number 5 we will remember is estimation of enzymes in aqueous humor. So what are the enzymes which are raised in retinoblastoma, which we are estimating in aqueous humor? One is your LDH. So all are raised. Then it could be phosphoglucoisomerase. Okay, so a lactose dehydrogenase, number 1, phosphoglucoisomerase. Right? We all know about lactose dehydrogenase. And the third we will learn is NSE, neuron specific enolase. Neuron specific enolase. All three of these enzymes are raised in patients of retinoblastoma. But let me tell you, we are not relying solely on this investigation, right? Alright, so these are the investigations. Exam question, what is the investigation of choice? Exam question, what is the investigation of choice? We will answer MRI. Okay? You don't want to expose the child to radiations and you want to see everything. So it's better to go for MRI to see both the intraocular, orbital and even the cranial conditions. So MRI. Right. We next talk about is pathology. Talking about pathology, we know that pathology of any tumor, we are going to learn as gross or microscopy. Gross, what are the 2 points we'll remember? One is necrosis and second is calcification, necrosis and calcification. So the calcification is important, as in the exam we just saw a slide where you could see the intraocular calcification due to retinoblastoma. Coming to microscope. Microscopic, we should know that retinoblastoma can be differentiated or it can be undifferentiated. Differentiated or undifferentiated. When you talk about differentiated forms, of course, this has a better prognosis. We have to be familiar with few terms. Again, this is asked in the exam. First is, what is Flexner-Winter-Steiner? So this pattern of differentiated cells, Flexner-Winter-Steiner, are cells with columnar cells with a central lumen. Let's have a look. If you see, these are columnar cells with central lumen. This is what is Flexner-Winter-Steiner. Right? We also call it rosates. These are rosates. Right on the second differentiated form is this one. These are called pseudo-rosates. These are pseudo-rosates and we call them Homerite. Homerite. And third, of course, is your fluorates. These are fluorates. So these are the differentiated form of tumor cells that we have to be, and Flexner-Winter-Steiner has been asked very recently in your exam, so we'll remember that. So let us note it down here. Homerite, Wright brothers wala right, okay? Homerite, and third I said is fluorates. We next talk about is genetics. Let's give the heading genetics. So we all know it's a genetic disease. What is the question asked in the exam is, which is the gene responsible? It is RB gene, of course, but where is it located? We will learn 13q14. It is a tumor suppressor gene, okay? Tumor suppressor gene. RB gene located in the position 13q14. You understand what is 13q14? Chalo, if this is, suppose, this is your chromosome number 13, Q is your long arm, P is a short arm of any chromosome. Again, an oversimplified depiction for us. So, it is 14th band. This is the place where you see the RB gene. Any mutation in the 14th band of long arm of chromosome number 13, this is leading to retinoblastoma. Now keep listening. If suppose the mutation extends outside the 14th band, now along with retinoblastoma, I will get dysmorphic features. What does dysmorphic features means? Facial deformities, flat nasal bridge, frontal prominent forehead and so on, frontal prominence. So this is dysmorphic feature with retinoblastoma. And this is what is called 13q syndrome. We call it 13q syndrome. Right? Okay, what is trilateral retinoblastoma? When both eyes you get retinoblastoma along with pineal gland tumor, we call the term trilateral retinoblastoma. So what is trilateral retinoblastoma? It is bilateral retinoblastoma with pinealoma. This is what is trilateral retinoblastoma. Okay? Okay. We next talk about is, what is the most common non-ocular? We have been talking about pinealoma, but is this the most common non-ocular malignancy? These days pinealomas are less common. So if they ask you most common non-ocular malignancy associated with retinoblastoma, answer becomes osteosarcoma. Okay, now we will answer osteosarcoma. Okay, so this is an autosomal inheritance of this retinoblastoma is autosomal dominant. And what next we have to understand is, what is Knutson's two-hit theory? What is Knutson's two-hit hypothesis? So Knutson's two-hit hypothesis. What does it say? Now this says that even if a person has genotypically inherited one gene, right? That means with only one inactive allele of the retinoblastoma gene. right? So, but you need another mutation, or understand this way. So, nuisance 2 hit means 2 mutations are necessary. Okay, I'm oversimplifying again. 2 hit means there has to be 2 mutations for retinoblastoma to manifest phenotypically. Got it? So now what can be the possibilities? One possibility is already there is one inactive allele of retinoblastoma gene which is inherited genotypically is there. Okay, if that is a somatic, if the somatic and somatic both mutations are on somatic cell, that can be one option. Second, one is somatic and one is germ cell. That could be another option. Okay, so 2 hits, either both the hits are at, so both are somatic, or one at somatic, one at germ. Common sense, if both somatic cells are involved, you are going to get a non-hereditary cases. And if the germ cell is involved, it is going to transfer the problem to the offspring. Therefore, these are hereditary cases. Okay? So, we have to learn here broadly, hereditary cases are 40% and non-hereditary overall are 60% of them. Hereditary cases are the ones which are generally seen bilateral. They generally are more than one, that is called multicentric, and these are the cases which are associated with osteosarcomas. Commonly, it is the hereditary cases which are associated with osteosarcoma. All of this information is very important, you should know it. Right. Now further, if you want to understand, if we talk about the cases of retinoblastoma as hereditary and non-hereditary, right? So one is hereditary and I said non-hereditary and non-hereditary, right? Okay. Now non-hereditary we are saying is 60% and hereditary we are saying is 40%. Now this hereditary case we can further divide as non-familial, means was in the family, positive family history is absent, it is non-familial, and familial means family history is present. So any hereditary case can be non-familial or familial. Now these non-familial cases are around 30 to 33%. Okay. And familial cases are anything from 6 to 10%. Now, what do we mean when we say a sporadic case? Sporadic cases means non-familial, non-hereditary, right? Non-familial, this is how much? 60. Non-hereditary, so the sporadic cases are around that will be ranging anything from 90 to 94%, right? 93% or 94%. Varies these percentages, but here it shows 90 to 93%. Okay, so this is how you have to understand. So what are the question that they have asked you is about percentage of sporadic and familial. So now I think we can answer around 94% if it is sporadic, then 6% of familial, and so on. They have also asked you the percentage of non-hereditary, hereditary, then you will answer 40%, 60%. If you will learn it once or twice, it won't be that confusing. Okay. Then we talk about, so you should remember this nuisance 2 hit hypothesis. It is important for you, right? What did I say? 2 mutations are important. Even if genotypically you have inherited one, your mutated cell is there, you need another to manifest it as phenotypic. Okay, talking about the staging of the retinoblastoma. We follow the ICRB staging, International Classification for Retinoblastoma. It divides it. Mainly it is concerned with intraocular tumors, which is stage 1. So stage 1, this is intraocular tumor. ICRB has divided this intraocular tumor into groups. Let's from A to E. Let's study this, learn together. When you say group A, I'm simplifying this for you. The size of the tumor is less than 3 millimeters size of less than 3 millimeters, and away from important structures, that is macula and optic disc. Okay, away from important structures. This is group A. What is group B? Just compare with group A and learn. Size of the tumor is more than 3 millimeter and it is near the macula or disc. This becomes your group B. Then C and D have to be compared. What is group C? Group C means this time we are not talking about the size, we are talking about distance. That means it is within 3 millimeters of, okay, write down what do we mean by group C is focal subretinal. You know what is a subretinal space. So it is focal subretinal or vitreous seeding which is seen within 3 millimeter of tumor. So we are talking about distance. This is what I wanted to say. Okay, so write it. Group C means we are talking about focal seeding. So the tumor has spread from the main tumor. This you see tumor cells, but it is focal seeding where in subretinal space, learn with me, and in vitreous. Within, this is important, it is within 3 millimeters of the tumor. Right? Then we come to what is group D. This time it is diffuse seeding. So C and D should be learned together. It is diffuse seeding again in the same, that is subretinal space. Learn with me, subretinal space and vitreous. Right? And this time it is not within, that is more than 3 millimeters from the tumor. Greater than 3 millimeters from the tumor. And then what is group E? Group E means it's a very large tumor which is filling half of the globe. Large tumor filling half of globe. Filling half of the globe. This is what is group E. Okay, so that was stage 1. What is stage 2? Stage 2 means that once you have removed the tumor, you find that okay, there is optic nerve involvement. So when there is an optic nerve involvement, we call it stage 2. And what is stage 3? Stage 3 is stage of extraocular extension. When you say stage of extraocular extension, we mean to say we are talking about orbital end. That means the tumor is in the orbit. Right? And what is stage 4? Stage 4 is distant metastasis. It is distant metastasis. Easy to learn? Okay. Once we are clear with the staging, very quickly, what is the treatment stage-wise? When you talk about stage 1, group A, this is a stage where you can just go for focal therapy. Right? So when you say focal therapy, I am targeting my treatment only to the site of the tumor. Either I can go for a cryotherapy or I can go for laser photocoagulation. What are these doing? They are damaging the blood supply of the tumor and therefore the tumor will regress. When should I use cryo? When should I use laser? Depends on the position of your tumor. Let's think together, all of you. Now suppose that the tumor is located posteriorly. I can hit it with the laser. But what if it is located anteriorly? Laser cannot bend. So for anterior tumors, we have to do cryo from outside. So cryos are mainly used in anterior lesions, that are peripheral lesions, right? Peripheral tumors, and laser you will say for posterior, that is central location, right? This is how you have to think. This was your focal therapy with laser or cryo done for group A. Come to the next group, B, C and D. Stage 1, what about B, C and D we learned together? Along with the focal therapy that you have learned, we also add chemotherapy. Right? So what are the drugs we use in the regime? We should know it is VEC. Easy to learn? Most important is E, that is etoposide. V is vincristine and C is carboplatin. Carboplatin. Right? So these are the drugs which we use in chemotherapy. What will you do in stage 1 and group E? We will go for enucleation. Just remember enucleation. Right? Stage 2. So when you say stage 2, now the optic nerve. So you did your enucleation, and when you are testing the end of the optic nerve, you see it is involved. What next to do? If there is optic nerve involvement, it is stage 2. You have already done the enucleation. So along with enucleation, we will also start with radiotherapy and chemotherapy. Right? This is your enucleation with radiotherapy, and so some places it is written radio is included, some not. Will take it as radiotherapy and chemotherapy. Okay? We come to the stage 3. What is stage 3? Stage 3 will be extraocular extension. So once the tumor is involved the orbit, you don't want it to spread to the brain, and that is risk to the life. Therefore, we go for exenteration. Right? And stage 4, palliative therapy. Not much can be done. We just go for palliative therapy. Okay? So this is the role, this is the treatment we follow for retinoblastoma according to the staging. Right, all of you? So that was about retina. I hope I am successful in simplifying the topic for you all and making it more interesting. Try to read it 2-3 times. Write your notes properly, and when you're going to read and revise all your Qs and double Qs, you are definitely going to find it easy. Thank you so much. Stay blessed. Keep smiling.